Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody to the last day of our course about diabetes made easy. We hope that 2 days before you got the benefit. We tried our best to cover the most important topics related to diabetes, and we try to do today to conclude this journey with some final topics. My first presentation today will be about insulin injection skills. We know the insulin injection needs practical skills. So we have to emphasize on these skills. I will try to do my best to explain it, and I have some videos for explanation because it needs like a hands-on practice. Just a reminder, if you are interested in diabetes and endocrinology, you can follow our Twitter account illustrated in front of you, EndoDMOS, ENDODMOS. It's a pure scientific account regarding diabetes and endocrinology. With no further delay, we'll start the presentation. My outlines for this topic will be about barriers to start insulin therapy, more details, methods of delivering the insulin, technique to draw up insulin using either vials or syringes, demonstrate where insulin is injection or injected and rotation of the sites, methods of disposing of the insulin delivery supplies, non-insulin medication that need to be delivered by injection. Before starting insulin, there are many questions by the patients and the family. For example, I am afraid of the needle. The other one, maybe I don't have time for this because busy like businessman, for example. Some patients may blame themselves and asking why me, why now? And some patients may be asking, is my diabetes getting worse if the physician decided or decides to give insulin for the patient. Barriers to start insulins are different, and including insulin means failure. This is the most common phenomena or fact will come to the mind of the patient. It means the patient is failed to control diabetes, and the only solution to go for insulin. The second point is insulin is not effective. Unfortunately, some facts in the social media correlating using of insulin with vision loss. Imagine, as a healthcare provider, we hear a lot, and one of the patients or some patients have concept that if the patient started on insulin may be correlated with a vision loss, which is definitely not related to insulin, and this is the social media effect, and you have to explain to the patient the truth. Next point is insulin causes complication or death. As I told you, insulin injection are painful, but with new technologies, with small needles, with insulin pumps, all these facts help the patient to minimize this effect. Fear of hypoglycemia, definitely insulin, if it is not received in the proper dose or in the proper way with a good instruction may cause hypoglycemia. So you have, as we mentioned yesterday, to educate the patient about the details of education, blood monitoring at home, how to adjust insulin, how to correct hypoglycemia, etc. Change in lifestyle, definitely if the patient start to receive insulin, he will be restricted to the time Sometimes if he is outside or she is outside the home, it will be difficult to receive the injection. That's why maybe they have to carry it out in a container, in a container or whatever it is. So again, these are one of the barriers before starting the insulin injection. Insulin causes weight gain, yes. Anabolic, we know that the insulin is anabolic, anabolic hormone, sorry. And one of the side effects of anabolic hormone, if it is received in this way, is weight gain. But if the patient restricted to the lifestyle modification, diet control, and weight loss regimen, definitely it will compensate this side effect. Insulin is too expensive. Fortunately, it is available in the Ministry of Health, and it is given free in the sector of Ministry of Health. But in the private sector, yes, it is expensive, and you have to consider the socioeconomic status for each patient individually. The good news about starting insulin. So it is not the dark, we can say, season or dark future always. There are good news about starting insulin. Insulin is one of the best ways to treat diabetes and lower your risk of getting complications and fast to get hemoglobin A1C in the target. Insulin is a natural substance made in your body, so it is not something different. Taking insulin does not mean you have failed, but this is the natural history, especially in type 2, as we mentioned yesterday. Any patient with a diagnosis of type 2 diabetes mellitus, it means 50% almost of this beta cell function is gone, and the patient will live the remaining of his life or her life with the remaining 50%. And the natural history, if even with this 50%, there is decline in the C-peptide. So definitely by time we need to give insulin from outside to overcome this, we can say, the deficiency of insulin hormone. Insulin injection do not hurt. You have, as we mentioned, give the choices, which is better now, including better needle or small needles. I think this slide, I tried to illustrate it yesterday, but here we have to go deep. You have to educate the patient about the proper sites of injection of insulin subcutaneously. And I will show it in details, how to inject, how frequent, and the correct way to use the insulin pen, or if the patient using insulin syringe, how should be used, and the type of insulin, the color of the pen, how many units, and which is the proper time. All of these are the educators or education points should be discussed before starting insulin to the patients. Again, insulin pen, what is the patient need to know? Insulin pen are either disposable or reusable. Most of the pens are reusable. For example, you will use 10 units today, and tomorrow you will use another 10 units. Etc. These are the most pens available, can be used many times. But again, some of the injectable medication, like for example, GLP-1 agonist, it is given once per week, and then it is disposable. You can take the or throw the syringe after the injection. You usually need a separate pen for each type of insulin and what type of insulin. These are the education points, as I mentioned. Pen needle come in different lengths and sizes, so you have to match it with your patient. Insulin pen provide patient satisfaction, increased likelihood of taking insulin, greater probability, less reported pain. So pens are better than the previous syringes, and more accurate. These are the pens available. You see the basal insulin like Glargine 2Geo, Glargine 300, and the old-fashioned is the Basaglar, which is Glargine 100, and we have Tresiba, which is Degludec, again, ultra long-acting insulin, and the boluses including Lispro, for example, and Novorapid, and we have a pre-mixed insulin like, for example, Novomix or Rhizodec. So the shorter and finer pin, like 4 millimeter, is better to be used. And this is the correct way to be given subcutaneously in the fat layer. So insulin is injected in the fat layer below the skin. The more you weigh, the thicker your skin. So as I told you, it depends on the patient if he is or she is obese or thin, because the subcutaneous tissue is different from patient to patient. Anyone can use short insulin needle. You don't have to pinch up before injection. So some of the injectable medication, as I told you, in the other groups, including GLP-1 agonist, and not only insulin, dulaglutide, liraglutide, for example, semaglutide, all of these are coming in pens for injection as well. The instruction: don't mix insulin and non-insulin medication together in the same injection. You may give an injection of a non-insulin medication and insulin in the same body area, but not right next to each other. Each medication has its own instruction for use and contraindication. So insulin syringes, what does the patient need to know? Insulin syringe come in 3 different sizes with 2 different needle lengths. What is the best for you? As I told you, depending on the weight of the patient, the skin layer, subcutaneous tissue, etc. The size syringe you see you use is based on your insulin dose. Using the right syringe help you draw up the correct dose, write down the name and size of the syringe you use, and instruct your patient. These are the general steps to use the vial for injection. Number 1 rule: the bottle if using cloudy insulin until insulin is mixed. Number 2, wipe top of the bottle with alcohol swab. 3, take caps off of the needle and plunger. Pull plunger down and use the instructed units, whatever given by the doctor. With bottle on the table, put needle into bottle, push plunger down, and push air into the bottle. Turn bottle upside down, pull plunger halfway down to draw insulin into the syringe, push insulin back into the bottle, pull plunger to how many units given or instructed. Check for air bubbles. If air bubbles are present, push insulin back into bottle and repeat steps 7 and 8. These steps are omitted or neglected if you are using pen, which is more easy. Hold the syringe like a pencil. If you like to inject, pinch up the skin and inject, and remove the needle definitely. Common injection issues: insulin drips from the needle, one of the side effects. Insulin leak from the injection site also can be observed. Bubbles in syringe or pen or syringe become clotted, or difficulty seeing the gauge on syringe, pain with injection, skin problems. All these side effects, or what can we say, undesirable effect can be seen if the patient is using the insulin. Tips for choosing injection sites. So this is again a very important issue. What are the sites in which you can inject the insulin? Maybe I will try to give more details here. For example, using your stomach, arm, or thigh, or buttocks are the site. it is very important to go for different sites. For example, this week you will use the stomach, next one you will use right arm, left arm in the next week, and then thigh, for example. Why? Because to prevent lipodystrophy in the skin. If repeated injection given in the same sites, lipodystrophy will develop, leading to less absorption, and definitely will be no benefit of the injection. So to prevent this lipodystrophy, like scars in the sites, you have to go for different sites repeatedly every time or every week, for example. In the stomach, avoid the navel and go 2 inches around it. Avoid scars and moles also. Watch out of the skin changes every time. As I told you, for example, lipodystrophy can be developed if patient receive all injection in the same place. Sometimes injection can lead to skin problems, as I told you, including lipohypertrophy. You see here, build up of the scar and bruising, for example, may occur, and lipoatrophy, pitting of the skin. So all these changes can be observed, but can be prevented if the patient is using the insulin, different sites of insulin injection every time. So what is the place best absorb insulin? This is an interactive question for the audience. Please, I need your input down in the chat box. Do you think the best absorbable site for insulin is A, abdomen, B, thigh, sorry, this is C for buttocks. So please write down your opinion in the chat box. I will give you a few seconds. So I see here most of the choices going between A, majority, and some of the choices going with B. I think most of the choices or your answers going with A. Yes, it is more in the stomach. Let us see this slide. Factors that affect insulin absorption. So the first column, including things that speed up absorption or factors that speed up the absorption, including injection into stomach or arm, injection into an exercised arm or leg, applying heat, taking smaller doses of insulin, massaging the area of injection. And in the second column, things or factors that slow down absorption, including injection into thigh or buttocks, injection into scarred or lumpy tissue, applying a cold compression, taking larger doses of insulin, and smoking. Injection should not hurt. Why? What could be a cause of the pain? Using alcohol to clean injection site is not advisable. Injection called insulin also may hurt. Reusing needle or using a bent needle is should not be done. Not using a thin enough needle, injection into muscles down deeply. All these factors may lead to the pain felt by the patient. Syringe and needle disposable. Syringe and pen needle are designed for one-time use, safely disposing of sharps. Check with local or state health department and do not recap or break needle. Place into puncture-proof container. Make sure lid is secure. Don't label as needles. Don't put recycle in a recycle bin. This is very important while you are dealing with syringes. You have to go for the container or the proper container for disposable. And now I will go for some of the videos. Some of the videos down here will illustrate it in a practical way, the injection technique. So I know it will take time, but you know, the injection is a practical skills, and it needs your attention to understand, or to have a general idea about this issue.
Lesson 1. Getting ready to inject. It's always important to wash your hands before each injection. It takes about 15 seconds to wash your hands properly. Check your injection site is clean. Insulin pens are available in reusable form and disposable. Always follow your pen manufacturer's instructions for use. Take your new pen needle and insulin pen. Check the expiry date on the label. Only use if in date. And then ensure that the seal is not broken. Do not use if the seal is damaged. Next, prepare your insulin pen device. Make sure you have the right insulin and check the expiry date, which is shown on the pen label or cartridge. Remove the cap from the pen. Peel the label off the plastic protective cap. Push the pen needle onto the insulin pen, ensuring the needle is attached in a straight line with the pen and that the needle goes through the rubber insulin cartridge seal. Locate the pen needle thread and then screw the needle onto the cartridge. Do not over-tighten, as it makes removal difficult. If the needle is not attached in a straight line with the pen, the rubber insulin cartridge seal can be torn and insulin will leak. The needle can bend and even break. If your insulin is the cloudy type, ensure it is properly mixed before use. If the insulin is the cloudy type, gently invert 10 times. And roll between the palms of your hands 10 times to fully mix it. After mixing the insulin, check to see it is evenly mixed and looks milky. Remove the outer cap and pull the inner cap off. Great, let's recap. Wash your hands before injecting. Check the injection site is clean. Check your insulin and pen needle expiry date. Check pen needle seal is intact. If your insulin is cloudy, fully remix it. Attach the pen needle in a straight line to the pen. Remove outer and inner cap. Now you're ready to inject. Lesson 2. How to inject with an insulin pen and pen needle. To ensure your pen and needle are working properly, always perform a test before injecting. To perform the test, dial 2 units of insulin. With the pen needle pointing upwards, push the dose button and look for a few drops of insulin at the needle tip. If no insulin appears, repeat the test. If no insulin appears after several attempts, consult your nurse, doctor, or pharmacist. Select the dose of insulin to inject. Hold the pen in your hand with your thumb away from the dose button, ready to press it. Gently push the needle through the skin at the injection site. Keep the pen and needle at 90 degrees to the skin surface. Fully push down the dose button with your thumb until the dial returns to 0, then count to 10. Keep the pen at 90 degrees. Moving the pen while the needle is in the skin may cause bleeding, bruising, and leakage. Now that the insulin has been injected, lift the pen and needle straight out from the skin. To remove the pen needle safely, point the pen and needle away from you. Reaching from behind, grip the needle between your thumb and finger and unscrew the pen from the needle. Drop the needle into the opening of the container from about 5 centimeters. Replace the cap on your pen device and store it at room temperature. You're doing great. Let's recap. Always perform a test dose before injecting. Inject at 90 degrees to the skin. Hold the needle in the skin for 10 seconds after you have fully depressed the dose button. Pull the needle out of the skin in a straight line. Remove the pen needle and dispose safely. Lesson 3. How to lift a skin fold for effective injection. In this lesson, you'll learn when you need to lift a skin fold, how to lift a skin fold properly, and to avoid making mistakes which may lead to injections into the muscle. Injecting into muscle increases the risk of hypo. Insulin injected into the muscle will be absorbed too quickly. If you are active, absorption will be even faster. If there is a risk of injecting into the muscle, you should lift a skin fold. If you're not sure, talk to your nurse or doctor. It is important to practice lifting a skin fold correctly. Put your hand in the correct position. Use only your first and second finger and thumb. With your fingers and thumb spread apart, push down onto the skin surface with your fingers and thumb so that you can see a small dip in the skin where your fingers and thumb are. Now squeeze your fingers and thumb together, drawing up a lifted fold of fat and skin. The fat should easily slide over the muscle layer and be easy to lift up. Once you have lifted a fold of skin and fat deep enough for your pen needle, inject your insulin, making sure to not release the skin fold until the injection is completed and the needle is withdrawn from the skin. Let's see what can go wrong when lifting a skin fold. Squeezing the skin fold too tight may make the injection difficult and could lead to you accidentally injecting into your finger or thumb. Using all your fingers and thumb, pushing in too deeply at the start and gathering up muscle, fat and skin may lead to an injection into the muscle, and this is what you're trying to avoid. Not squeezing your fingers and thumb together sufficiently can lead to the lifted fold of fat and skin being too soft, which will easily squash under the pressure of the pen and needle, leading to accidental injection into the muscle. Releasing the skin fold before the injection is complete may also lead to an injection of insulin into the muscle. Once you have a lifted fold of skin and fat deep enough for your pen needle, you're ready to inject your insulin. Great job! Let's recap. Injecting insulin into the muscle may cause hypos. Correctly lifted skin fold reduces the risk of injecting into the muscle. Always use a skin fold when the needle you're using has a risk of passing through the fat layer and entering the muscle. Speak to your nurse or doctor and ask them to show you how to correctly lift a skin fold. Lesson 4. How to prevent lipos developing. In this lesson, you will learn the importance of correct rotation in preventing lipos and how to rotate your injection sites correctly. The goal of correct rotation is to inject into the same spot as infrequently as possible. Correct rotation has the strongest protective value against lipos. A proven method that helps to prevent lipose is the zone system of rotation. Use one zone for a week and then move to the next zone. Within each zone, use a new injection spot each time for a week before moving to the next zone. Each injection should be at least 1 finger width away from the last. This will help ensure correct spacing of injections and full use of the zone for 1 week, or until the zone is used, and then move to the next. Some types of insulin cannot be injected into the same area within 24 hours because they may react with one another. It is very important that you speak with your nurse or doctor before making any changes. A new needle will pass through the skin and the fat layer smoothly and comfortably with minimal damage to the skin. Reusing pen needles may cause pain and discomfort, but importantly has been shown in some studies to be linked to growth of lipose. Correct rotation means using the whole injection area. Because the fat layer can be very thin in some places, it is important to always use a 4 mm pen needle and sometimes a lifted skin fold to reduce the risk of accidental injections into the muscle. The thigh injection area in most people has a very thin layer of fat. Using a 4 mm pen needle will reduce the risk of injections into the muscle. Some people may also need to lift a skin fold. Speak with your nurse or doctor to check. Brilliant! You're making great progress. Let's recap. Correct rotation of injection sites helps to protect you from lipose. Use the full area and the zone system. Each injection spot should be 1 finger width from the last. Use 1 zone per week. Use a new needle every time. Use a 4 mm pen needle to reduce the risk of injections into muscle. Speak to your nurse or doctor before making any changes and check if you need to lift a skin fold. Lesson 1. 5 steps to healthy injection sites. In this lesson, you'll learn why it's important to keep your injection sites healthy and how to. Lesson 1. 5 steps to healthy injection sites. In this lesson, you'll learn why it's important to keep your injection sites healthy and how to take care of them. Caring for your injection sites is very important. Injecting repeatedly into the same spot can lead to a complication called lipohypertrophy, or lipo for short. Injecting into lipose delays insulin absorption, which leads to blood glucose ups and downs, and even hypos. To learn more about correct site rotation, go to Course 2, Lesson 4, How to Rotate Your Injection Sites. These 5 simple steps will help you keep your injection sites healthy. 1. Check your sites frequently. 2. Inject into healthy sites only. 3. Always use clean hands and clean sites. 4. Rotate your sites correctly and 5. Always use a new needle every time. Before injecting, always be sure that your injection site is healthy. You should only ever inject into a clean and healthy site. If you're not sure how to check, ask your nurse or doctor. Do not inject into unhealthy sites. If you notice any signs of lipohypertrophy, swelling, scarring, redness, inflammation or infection, do not proceed. Talk with your nurse or doctor if you are unsure or have any concerns about your injection sites. Always inject into a clean site with clean hands. Always wash your hands properly before you inject and dry them thoroughly. clean your injection site with soap and water if needed. Always rotate your injection sites. Correct rotation protects you from injection site complications, which helps you achieve target blood glucose control. To learn more about correct site rotation, visit Course 2, Lesson 4, How to Rotate Your Injection Sites. Always use a new pen needle for each injection. Reusing pen needles can lead to lipose, needle damage, discomfort or pain, needle blockage, which can lead to an incomplete dose of insulin. The symbol on every box of pen needles means use once only. It is best to attach a new pen needle just before each injection. Well done. Let's recap. Always check your injection site before injecting. Inject only into healthy sites. Inject into a clean site with clean hands. Always rotate injection sites and use a new pen needle every time. Lesson 1. Why use a 4mm needle? In this lesson, you will learn why a 4mm pen needle is more comfortable and less painful than longer needles, and how to get the insulin into the right place so it will be absorbed in the right way. Understanding what is under the skin surface of your injection sites will help you ensure that insulin is always injected into the fat layer where it will be absorbed predictably and steadily. Skin over injection sites of adults is on average 2 mm thick, regardless of your age, gender, weight or ethnicity. It's good to know skin is 2 mm thick, as this helps you choose the best needle length for insulin injections. Under the skin is the subcutaneous fat layer. Unlike the skin, fat thickness is highly variable. It varies from person to person and from site to site, and even across one injection site. The blood flow in the fat layer is very stable and predictable. This makes it perfect for insulin injections. By injecting into the fat layer, you can be sure that your insulin will always work in the same way every time. The muscle layer below the fat is very rich in blood vessels. The blood flow can vary depending whether you are resting or active. This makes muscle a very bad place to inject insulin. The rich and fast blood flow speeds absorption of insulin and may cause hypos. 4mm pen needles help to get insulin into the fat layer with a low risk of injecting into the muscle. The latest generation of very short and thin pen needles with special needle tips make injections much more comfortable. To learn more about 4mm pen needles, speak with your nurse, doctor or pharmacist. All people who inject insulin are recommended to use a 4mm needle. 4mm pen needles, when used at 90 degrees to the skin surface, will pass through the skin and inject insulin into the fat layer below with very low risk of entering the muscle. Clinical studies show that most people prefer injecting with a 4mm pen needle, finding it more comfortable and less painful than either 5mm or 8mm. Using 4mm pen needles also helps avoid injecting into the muscle. Brilliant! Let's recap. The skin is on average 2 mm thick for most adults at all injection sites. The 4mm pen needle will pass through the skin and deliver insulin into the fat layer, helping to avoid injection into muscles and improve comfort when injecting. Lesson 4. How to rotate your injection sites. Studies have shown that injecting insulin into an area the size of a credit card or less may cause lumps to form, which are called lipohypertrophy, or lipo for short. Injecting into these lumps can lead to ups and downs in your blood glucose level and can cause unexpected hypoglycemia. Keeping injection sites healthy means using one injection spot as little as possible. Studies show that people who use larger areas to inject have much healthier injection sites, less blood glucose ups and downs, and fewer unexpected hypos. Follow these rotation guidelines, which may help you to achieve better day-to-day blood glucose control. Divide your injection areas into zones. The abdomen has 4 zones. The thighs have 2 zones. The buttocks have 2 zones and another 2 zones if the arms are used. Depending on the type of insulin you use, you can inject into one zone for a week before moving to the next zone. Keep this up, and it could be as much as 6 to 8 weeks before one single injection spot is used again. Keep each injection site about at least the width of one finger away from the last. Keep spacing injections 1 finger width apart for the whole zone for 1 week or until the zone is used up. Start a new zone. Keep injections 1 finger width apart for 1 week until it's time to move to the next zone. Keep doing this until you go back to where you started. Following this pattern of injection will mean that each injection spot will only be injected once every 6 to 8 weeks. Insulin analogues must not be injected into the same area within 24 hours. Some human and NPH insulin types are better injected in different areas at different times of the day. It is important to speak with your nurse or doctor and adjust the rotation system to match your insulin type and your needs. Ask your nurse or doctor about using a rotation grid. Some people find the grids helpful as they show the size of the area in which you can inject, the individual zones, and help you with spacing your injections. Well done! Let's recap. Inject insulin into your abdomen, thigh, buttock and arm areas. Divide each area into zones. Rotate injection sites within each zone. The goal is to inject in one spot as little as possible. Some insulins need a different rotation type, so always speak to your nurse or doctor before you start rotation. Now you know how to correctly rotate your injection sites. If you stick to using large areas and rotating your injection sites, you can help keep your injection sites healthy and your blood glucose under control.
Hi, I'm Dr. Emily Walker, a VA pharmacist, and I would like to discuss with you the proper way to give yourself insulin using an insulin pen. There are many different types of insulin pens available from the VA. In this video, I will be demonstrating one specific type of insulin pen called the Flex Pen. Other names of insulin pens prescribed by your provider may include Flex Touch, Solostar, or Quick Pen. What is important for you to know is that the correct technique that I will show you in this video is very similar to what you would use for any of the other insulin pens mentioned. Remember, what insulin to use, how much to give, and when to give yourself the insulin will be told to you by your VA provider. Let's get started. When you're preparing to give yourself insulin, you want to make sure that you place all the proper supplies on a flat surface ready to go. These supplies include your insulin flex pen or whatever insulin pen you may be using, your pen needles, an alcohol swab, and a sharps container. If you do not have a sharps container, you can use a heavy plastic container such as an old laundry detergent bottle and write used needles on the side with a permanent marker. Before injecting yourself, wash your hands with soap and water. When your hands are dry, pull off the pen cap from the insulin pen and set it aside. Next, inspect the insulin through the viewing window. Do not use the insulin if you notice a change in color or if you notice things floating in the insulin. By inspecting the insulin pen, you will also be double checking that you have the correct type of insulin. As I mentioned already, for our example today, I'm using the Novolog Flex pen, which has been pre-filled with insulin aspart. After inspecting the insulin pen, put it down and open an alcohol swab. Wipe the rubber stopper on the end of the insulin pen with the swab. Allow the rubber stopper to air dry completely. Do not blow on the rubber stopper to dry it, as this will introduce germs from your mouth. Next, pick up the pen needle and remove the protective paper covering. Grasp the base of the pen needle and carefully screw the pen needle onto the insulin pen. Make sure the pen needle is screwed on straight and hand tightened so that it pierces the rubber stopper completely. Make sure you do not over-tighten the pen needle, as the pen needle base is plastic and can crack. Next, pull off the clear plastic outer needle cap. You will see a second inner needle cap still covering the needle. Remove the inner plastic needle cap. Both plastic caps can be disposed of in your regular household trash. It is important to always use a new pen needle for each injection to reduce the risk of infection. Never reuse or share needles with your family or friends. Next, we will complete an air shot with the insulin pen, which should be done before each injection. An air shot is sometimes called priming. Doing so removes any air that is trapped in the needle. Turn the dial up to 2 units. Hold your insulin pen with the pen needle pointing straight up and lightly tap the insulin pen with your finger a few times to make sure any air bubbles move to the top. Next, press the push button all the way in. The dial should return to 0. You should see a drop of insulin appear at the tip of the pen needle. If the drop does not appear, repeat the process. This can be repeated up to 6 times. If it still does not work, try using a new pen needle. If that doesn't work, then try a new insulin pen. Next, select your insulin dose. Check to make sure the dial is set to 0, then turn the dial selector to the desired number of units. The pointer arrow should line up with your desired dose. The dose can be corrected up or down by turning the dial. For example, if you are prescribed insulin aspart 10 units before meals, you will dial up to 10 in the pen window while making sure the arrow lines up with the desired number of units. Be careful not to press the push button while selecting your dose, or the insulin will come out prematurely. You will hear a click for each unit you dial. It is not recommended that you attempt to dose based on how many clicks you hear, as this may result in an incorrect dose. Please note, towards the end of the insulin pen use, you will not be able to dial more than the number of units remaining in the insulin pen. Next, if your skin is not clean, use an alcohol swab to clean the site before injection. If you just bathed, you may not need to clean the area with alcohol. Remember, alcohol can be very drying to your skin, so you don't want to apply alcohol to your skin if not needed. Insulin can be injected into either your abdomen or stomach area, buttocks, on the high hip upper outer area, thigh, or upper arm. That is the back, fattier part of your upper arm and not the muscle area. The needle you are using is thin and may bend. You may find that pinching your skin gently before injection can prevent bruising and decrease the chance of bending the needle. It is recommended that you rotate to different sites each time you use the insulin pen. If you plan to be physically active right after the injection, it is recommended to rotate around your stomach area only, rather than to the arms, legs, or buttocks. Avoid injecting insulin into any area of skin that has pits, is thickened, or has lumps. Avoid injecting where the skin is tender, bruised, scaly, or hard. In addition, stay 1 to 2 inches away from your belly button, scars, or skin with open wounds. If you are injecting more than one type of insulin, use different injection sites, as the insulins won't work as intended if injected in the same site together. For instance, give your basal or long-acting insulin on the left side of your stomach, and then give your bolus or rapid-acting insulin on the right side of your stomach. Insert the insulin pen into your skin straight in and not angled. Again, if there is not enough fatty tissue, pinch a 1 to 2 inch portion of skin in fact. Once the insulin pen needle is inserted into your skin, keep it in place and press the push button on the insulin pen all the way in, and maintain it pressed until the arrow next to the dial returns to 0. Keep it pressed for a full 6 seconds after the dial is at 0 to make sure all the insulin is injected. Now you can remove the insulin pen. A small drop of insulin may appear at the end of the needle. This is normal and can be expected. If a drop of blood appears on your skin after you remove the insulin pen, press the injection site lightly with a gauze pad. Do not rub the area. Once the injection is completed, do not recap the needle, as this can cause an accidental needle stick injury. Remove the pen needle from the insulin pen by grasping the sides of the plastic hub and twisting. Discard the pen needle into the sharps container. Place the pen cap back on and store the insulin pen in a safe location. Your insulin pen can be stored at room temperature below 86 degrees Fahrenheit for up to 28 days, away from heat or light. It is recommended that you keep your unused insulin pens in the refrigerator between 36 to 46 degrees Fahrenheit, as the insulin pens can be safely stored until the expiration date on the label. Never freeze insulin. When the insulin pen has been completely used up, it will not allow you to give any additional doses. At that time, you can discard your insulin pen with the pen needle removed into your household trash. The pen needles should always be placed into a sharps container. You have successfully given yourself a dose of insulin using an insulin pen. Good job. I thank you for your service to our country, and I'm honored to be of service to you this day.
I hope that it was clear for all of you. I know it is long, but you know, this is practical steps or tips. It is very important to understand the clinic tips, practical tips related to the injection. So we'll go now for the next topic. And the next topic will be about how to deal with diabetes in older population. We know that dealing with diabetes is different from in many aspects, including special population like elderly people, pediatric age group, gestational diabetes during pregnancy, etc. I will try to focus on older population, how to deal with them according to the recommendation illustrated by the guidelines. So older adults who are functional and cognitively intact should receive diabetes care with goals similar to those developed for younger adults. This is a very important point. Glycemic goal for some older adults might be relaxed using individual criteria, but hyperglycemia leading to symptoms or risk of acute hyperglycemia complication should be avoided in all patients. So the message here is sometimes you may accept 8 or 8.5 A1C, but if patient, older people or elderly is healthy, it should be, you have to deal with the patient as the younger people. The other cardiovascular risk factor should be treated in older adults with consideration of the time frame of benefit and individual patient. Why? Because being tight and restricted may lead to hypoglycemia, and we know especially in elderly, hypoglycemia will be more dangerous than hyperglycemia. So you have to go with the maneuver according to the situation or clinical situation available. The treatment of hypertension is indicated in virtually all adults, older adults, and lipid and aspirin therapy may benefit those with life expectancy at least equal to the time frame of primary and secondary prevention trial, and I will show you the details in the timetable. Screening for diabetes complication should be individualized in older adults but particular attention should be paid to complication that would lead to functional impairment. Diabetes is an important health condition for the aging population. At least 20% of the patients over the age of 65 have diabetes, and this number can be expected to grow rapidly in the coming decades. Older individuals with diabetes have higher rate of premature death, functional disability, and coexisting illnesses such as hypertension, heart disease, stroke, than those without diabetes. Older adults also with diabetes are also at greater risk than other older adults for several common geriatric symptoms, including polypharmacy, depression, cognitive impairment, urinary incontinence, injurious falls, and persistent pain. The care of older adults with diabetes is complicated by their clinical and functional heterogeneity. Some older individuals develop diabetes years early and may have significant complications. Others who are newly diagnosed may have had years of undiagnosed diabetes with resultant complication, or may have truly recent onset disease and few or no complications. Some older adults with diabetes are fragile and have other underlying chronic conditions, substantial disease, related comorbidities, or limited physical or cognitive function. Other older individuals with diabetes have little comorbidities and are active. So this is the framework in which you have to concentrate while you are dealing with elderly population with diabetes. The framework, including the patient characteristic, what are the comorbidities, the first column. Then you may go for the reasonable hemoglobin A1C, and next one is the fasting and postprandial and bedtime glucose target, blood pressure target as well, and lipid goal also. So we'll go one by one. The first category is it is called healthy elderly. They have few coexisting chronic disease, intact cognitive and functional status. It is reasonable to keep A1C as 7.5 and less. So elderly people with a health condition, with a good health, general health condition, with few coexisting chronic disease, A1C 7.5 and this is the goal in these people. Fasting glucose target between 90 up to 130, bedtime between 90 up to 150, blood pressure less than 140/80, and statin can be given unless contraindicated or not tolerated. The second category related here to our topic today is the complex and intermediate people. It means they have multiple coexisting chronic illnesses or more than 2 instrumental ADL. And ADL, instrumental ADL, daily activity, I will mention it later on, impairment or mild to moderate cognitive impairment. In this situation, keep A1C less than 8% and fasting sugar target between 90 and 150, postprandial the bedtime 100 up to 180, blood pressure less than 140/80. Statin also can be used unless contraindicated or not tolerated. The next category, it is a very complex patient with a poor health. It means they have long-term care or they need long-term care or end-stage chronic illnesses or moderate to severe cognitive impairment, or we have deficiency in 2 or more daily activity, dependence daily activity. In this situation, we have 8.5, and this is the target of A1C. Fasting sugar target between 100 up to 180. The sugar at bedtime should be 110 up to 200, and the blood pressure 150/90 or less. The considered likelihood of benefit with the statin can be also used as secondary prevention more than the primary in these people. What are the notes should be taken in consideration? The patient characteristic categories are general concept. Not every patient will clearly fall into a particular category. Consideration of patient or caregiver preference is an important aspect of treatment individualization. Since yesterday or day before yesterday, in a clinical point is individualization. Please don't assume all guidelines for each patient. Individualization according to the clinical status. You have to be flexible, and you have to choose the proper way for your patient according to the clinical scenario in front of you. Patient health status and preferences may change over the time. There are few long-term studies in older adults demonstrating the benefit of intensive glycemic blood pressure and lipid control. As with all patients, the education and ongoing education are vital component of diabetes care. Diabetes self-management education is, as I told you yesterday, is very crucial. In patients with advanced diabetes complication, life-limiting comorbid illness or substantial cognitive or functional impairment, it is reasonable to set less intensive glycemic target goal. Hypoglycemia in this population is more risky. Please take this message. Hypoglycemia is more risky in elderly. These patients are less likely to benefit from reducing the risk of microvascular complication and more likely to suffer serious adverse effects from hypoglycemia, leading, for example, to loss of the conscious level and brain damage may be occur. However, patients with poorly controlled diabetes may be subjected to acute complications of diabetes, including dehydration, poor wound healing, and hyperglycemia, hyperosmolar coma. So benefit-risk ratio should be measured in each patient according to the individual approach. Glycemic goal at a minimum should avoid these consequences, although hyperglycemia control may be important in older individuals with diabetes. Greater reduction in morbidities and mortalities may be resulting from control of other cardiovascular risk factors rather than from the tight glycemic control alone. There is strong evidence from clinical trial of value of treating hypertension in the elderly. Special care is required in prescribing and monitoring pharmacological therapy in older adults. Cost may be a significant factor, especially since older adults tend to be on many medication with a polypharmacy. Metformin may be contraindicated due to renal insufficiency or significant heart failure. TZDs like Actos or pioglitazone should be used very cautiously in those with heart failure because it is associated also with fracture and overloaded or fluid overload. This is the activity of daily living which may be lost, and according to the daily living activities, you can categorize your patient. So you have the mnemonic of ADL. It is called, or activity of daily living, it is called BATIT. B for bathing, his or she is able to bath herself, and A for amputation, if she has amputation or ambulation, sorry, she can or he can be ambulated or walking. Next one is toileting, going to the bathroom. Transfer from the bed, for example, to the chair, also is the first T, and the second T is eating, and finally we have the dressing, able to dress him or herself or not. So if we have more lost activities, definitely we'll go for the third category or last category, It means patient, you have to be loose with him in the glycemic control. But if more preserved activity, you will go for the first or second category, according to the criteria I showed you previously in the framework. The lower goal than that mentioned in schedule above may be set for an individual if achievable without recurrent hypoglycemia. So this is, I told you, the message. Checking hypoglycemia, very important because it may go for more serious side effects. Coexisting chronic illnesses or conditions, examples including arthritis, carcinoma, heart failure, depression, emphysema, falls, hypertension, incontinence, chronic kidney disease, myocardial infarction, and stroke. By multiple chronic illnesses, we mean at least 3, but many patients may have 5 or more. The presence of a single end-stage chronic illness, such as stage 3 to 4, congestive heart failure or oxygen-dependent lung disease, chronic kidney disease requiring dialysis, or uncontrolled metastatic carcinoma may cause significant symptoms or impairment of functional status and significantly reduce the life expectancy. A1C of 8.5, which is mean the average blood glucose of 200, lower glycemic target, then this may expose patient to acute risk from glycosuria, dehydration, hyperglycemia, hyperosmolar syndrome, and poor wound healing. Sulfonylurea, other insulin secretagogue, and insulin, you have to be cautious in elderly because high risk of hypoglycemia. Insulin use require that the patient or caregiver have good visual and motor skills and cognitive ability. Imagine elderly patient with vision impairment, and you are prescribing insulin. The patient will be, it is difficult for the patient to go for the proper number to extract the insulin or to choose the proper number in the insulin pen. So reading the general condition of the patient and the family is very important while you are prescribing insulin. But if caregivers are available, or some of the, we can say, a family member or attendant at home or nurse at home who take care, you can go ahead definitely. DPP-4 inhibitor have few side effects, but cost may be barrier. Also GLP-1 agonist with the side effect, you have to think about it before giving it to the elderly people. Screening for diabetes complication in older adults should be individualized. As I told you since yesterday, particular attention should be paid to complications that can develop over a short period of time and or that would significantly impair functional status, such as visual and lower extremity complication. Take home message from this topic: try to balance between benefit and risk ratio. If you it is your decision according to the patient general condition. Thank you for listening. I think now we'll go to the next topic. I hope it was beneficial for all of you. I will share now the next topic. The next topic, as you see here, the insulin pump. Since yesterday, we mentioned a lot about insulin pump, some indications, some facilities related to the insulin pump. So we'll give some brief here in this topic. What is the insulin pump and what is the definition? Definition: it is a pump is a medical device used for administration of insulin to treat diabetes. It is known as continuous subcutaneous insulin infusion. So if you see this terminology, CSII therapy, it means you are dealing with this insulin pump. It is alternative to multiple daily injection or basal bolus regimen, which we mentioned yesterday by insulin syringe or pens. It is considered an intensive insulin therapy when used in conjunction with blood glucose monitoring and carb counting. The position nowadays and in the future, it is roughly 20 to 30% of patients with type 1 and fewer than 1% of insulin-treated patients with type 2 use an insulin pump. In 2007, the United States FDA estimated that the number of patients with type 1 using pump was around 375,000. Estimated pump use around the world, you see here the maximum in the United States of America, and the other countries are down, but the number is increasing by time. The usage in 2001, it's about 162,000 increase over the time. By 2050, it is expected to up to 1/3 of United States residents may have type 2. Many of these individuals will be insulin requiring. More clinicians must develop a comprehensive understanding of these devices. The insulin, as we mentioned yesterday, developed in 1921. Insulin is a hormone produced by the pancreas. Insulin enables the body to use glucose. Before the discovery, children with diabetes were expected to live under 1 year only. Diabetics cannot produce insulin, so it is given by the body. The history of insulin pump, as you see here, it was in the beginning like a huge device. The first insulin pump was developed by Dr. Arnold Kadish, 1963. A huge device can be carried, or it should be carried to the back as bag, a huge device. In 1976, Kamin invented the first wearable insulin pump. 1980, insulin pumps start to enter the market, and we have Minimid and Distronic. In Minimid 502, first popular insulin. 2003, Minimid 512, first insulin pump to monitor blood glucose. You see the pumps down. Many pumps after time start to be smaller and smaller with many companies available. The component of each pump contains the following of traditional pump. The first one, the pump itself, which control the control pad, processing module, and batteries. And number two, disposable reservoir of the insulin inside the pump. And the third one, disposable infusion set, including a cannula, subcutaneous insertion, and tubing system to interfere or to introduce the insulin reservoir to the cannula. And there was many videos will be introduced to you to see how it is working. Here is the component of the insulin pump. We have tube, we have the reservoir, we have the display, insulin set, and cannula. These are the usual component, and the cannula is fixed subcutaneously for every patient. Pump component, as I told you, insulin pump itself, and then you have catheter or catheter subcutaneously to introduce the insulin to the patient. Using an insulin pump, insert a needle anywhere into body, typically in the abdomen, more easy. 3 programmed ways to deliver the insulin, including basal rate. This is very important. You will go for basal rate to infuse insulin continuously 24 hours per day. This is the first set you have to do. Bolus dose, you have to adjust the bolus. Once patient is eating, a patient will enter how many carbohydrate he or she eats, and automatically, according to the carb counting ratio, the pump will deliver the proper dose of rapid-acting insulin. Correctional doses according to the blood glucose entered. For example, patient has blood sugar of 300, patient will enter the number into pump, and accordingly, patient our pump will deliver a proper corrective dose of rapid-acting insulin. Who are the candidates for the pump? Not any diabetic patient are candidate for the pump. Compliance is the very crucial point. Patient should be compliant. Currently performing more than 4 times per day injection and self-monitoring blood glucose 4 times per day or more. So before you prescribe the insulin pump, patient should be on self-monitoring blood glucose at least 4 times per day, multiple daily injection or basal bolus 4 times per day. Why? Because it is crucial to check for blood glucose 4 times per day, at least once patient is using pump. Pre-meals, how many, what is the blood sugar reading and how much carbohydrate patient will eat. Accordingly, the delivery of the rapid-acting insulin will be there. A patient should be motivated to achieve optimal blood glucose, contact with their healthcare team, hemoglobin A1C is not controlled, and special clinical situations also. So this is the American Clinical Endocrinologist Guidelines. Clinical characteristic of suitable insulin pump candidate in type 1 patient with type 1 who do not reach glycemic goal despite using multiple daily injection, labile diabetes, frequent severe hypoglycemia and hypoglycemia unawareness, glycemic emergency like recurrent diabetic ketoacidosis, Down phenomena also, patient with pregnancy, adolescent people, and competitive athletes. So these are the consideration. You have to keep it in your mind in type 1. What about type 2? Can be given also, but in patient with positive C-peptide, patient with erratic lifestyle, for example, frequent long distance traveling, shift working, comorbidities like, for example, gastropathy, severe insulin resistance with high requirement of high insulin doses. So all of these also we talked about. So specific characteristic for patients who are not good candidate for insulin pump. So we mentioned what are who are the candidates. But now we are talking about the people or the patients who are not candidate to receive insulin pump. And number 1, patient not performing multiple daily injection, like 3 to 4 per day, frequent self-monitoring blood glucose, as we mentioned. Number 2, lack of motivation to achieve diet blood glucose control. Number 3, history of non-adherence to insulin. Number 4, history of serious psychological or psychiatric conditions. Number 4, substantial reservation about pump use interfering with a lifestyle, like contact sport or sexual activity. Finally, unrealistic expectation of pump theory. Some people believe that it eliminates the need to check blood glucose. Unfortunately, most of the patient thinks that just fixing the pump will resolve the diabetes. No, you have to enter blood glucose, you have to enter a carb counting. Or inserting insulin pump does not mean a success story in all patients, but failure may be there. General guidelines also, all patients should have periodic re-education and training or retraining to address the knowledge and gap. Team should periodically re-evaluate whatever pump therapy is appropriate for the patient. School and hospital should be provided with manufacturer's information describing insulin pump use along with the contact to answer questions and provide further training. Provider should have on-call system available 24 hours per day to handle patient questions. Keep backup supply on hand in the event of a pump or infusion set failure. Patient families should undergo periodic retesting of skills to maintain patient safety, and this is the role of educators with a doctor definitely should be there. The adult patient at pump initiation, the patient should have a daily contact with the pump trainer, return visit within 3 to 7 days of initiation should be there. Education consult should be scheduled weekly or bi-weekly at first, then as needed. A specialist follow-up visit should be scheduled at least monthly until the pump regimen is stabilized. Patient families should be trained to handle emergency situation. Who will take care? The team of pump, including diabetes educator, dietitian, experienced diabetologist or endocrinologist. About 2,000 United States physician prescribe insulin pump, for example. Only providers whose practice can assume full responsibility for a comprehensive pump management program should offer the technology. Insulin pump on the market, as you see, many companies available, many shapes, many colors, many ways to deliver the insulin pump, including Medtronic, for example, Omnipod, the Minimed, etc. So according to the budget of the patient, according to the positive available or we can say advantages available, patient and healthcare provider will select the proper insulin pump according to the situation. Pump use in hospital setting, the specialist responsible for patient ambulatory pump management should be contacted to make decision about infusion adjustment. Hospitalized patient and their admitting physician should be encouraged to not discontinue the pump infusion and should consult a specialist as needed. Here are the calculation, how to go for calculation of insulin pump setting. Just a quick brief, you have to first calculate total daily dose by insulin pen, and maybe you can use the pre-pump total daily dose multiplied by 0.75, or the other method, weight in kilogram multiplied by 0.5. Maybe you can, after that, clinical consideration on pump total daily dose, average value from both methods. This is your total daily dose by the pump. Hypoglycemic patient start a lower value, definitely hyperglycemia. The patient has or pregnant, maybe you go for higher value, and then you have to calculate the following. Pump first basal rate, continuous insulin, rapid acting insulin, which is calculated by pump total daily dose multiplied by 0.5 over 24. It will give you how much you will give per hour, and then you can enter it through the pump itself. Start with 1 basal rate, adjust according to the glucose trend over 2 to 3 days, adjust to maintain stability in fasting state, add additional basal according to the diurnal variation. Number 2, you have to calculate the carb ratio, how much is the carb ratio for your patient, how to calculate it through this formula, 450 over total daily dose, and according to this number, you enter it to the pump, and automatically, if the patient eats, he will enter how many carbohydrate. According to the formula, he will receive the proper rapid-acting insulin. And sensitivity correction factor, according to the formula, 1,700 over pump total daily dose. It needs for correction. For example, more than 300, patient will enter that blood sugar is 300. Accordingly, the pump will go for calculation by this formula and will give the proper rapid acting insulin for correction. Again, so this is how to do it. Method 1 and method 2, take the average, go for basal rate, carb ratio, sensitivity, enter it to the pump. Continuous subcutaneous insulin infusion or insulin pump. With pump therapy, basal insulin is supplied in the form of a continuous infusion. A variety of insulin pumps are available, and the choice among pumps is largely a matter of patient preference and lifestyle as we mentioned. The choice of insulin, we know only short-acting or rapid-acting insulin used in insulin pump. Rapid-acting like Lispro, Aspart, Glulizine, typically preferred over regular insulin. In meta-analysis, a trial comparing rapid-acting insulin with regular insulin, there was a small but significant reduction in A1C with use of insulin analog. Inserting insulin infusion, insulin set guidelines avoid inserting the infusion set into 2-inch area around the belly button or umbilicus, as we mentioned before, which is about 5 centimeters, where your body naturally bends a great deal, in area where clothing might cause irritation, where you have a scarred or a scratch mark, again, you have to avoid. Your infusion site should be at least, as we mentioned, 5 centimeters away from sensor site, from belly button, 5 centimeters, and 7.5 centimeters from a previous site. What are the places? As usual, in injecting sites, including the belly, including the buttocks, arm, and thighs. Location for inserting glucose sensor. If some pumps comes with sensor, you can insert it. Shown here are the best body area for the sensor insertion around the umbilicus. Avoid insertion, as we mentioned, 5 centimeters around from belly button as well. So what is the usual mechanism here? The sensor, if there is hypoglycemia, will give alarm through Bluetooth to the pump to hold the infusion of the insulin. After insertion, blood glucose monitoring using a glucose meter to read the test strips should be done 4 to 7 times daily. Ideally before meals, mid-morning, mid-afternoon, before bedtime, and occasionally at 3 a.m. With continuous glucose monitoring, CGM, blood glucose level are reported in real time. CGM does not eliminate the need for capillary blood sampling for calibration and confirm hypoglycemia level. A1C should be tested regularly to determine chronic blood glucose control. Pros and cons of insulin pump. Pros including a slight better glycemic control, fewer injection, less variable insulin absorption, life flexibility, capability to store history of bolus basal for the clinician for review, decreased frequency of hypoglycemia. But in multiple daily injection, it is lower cost and freedom from wearing pump. Cons in the opposite for both insulin pump and multiple daily injection. The cost is high in the insulin pump therapy, superficial infection, pump failure may lead to DKA, inconvenience because a patient wearing it 24 hours daily. But the multiple daily injection, we have a multiple injection per day, inferior glycemic control, less flexibility. A1C reduction in general, if you compare it with the pump previous and post-pump, generally, we have a better outcome definitely with the pump, but if the patient is adherent and motivated. And the risk of hypoglycemia definitely is better if you compare pre-pump situation with the post-pump situation as their study. What is the continuation rate? Definitely more than 97% of the patients like to continue on pump, but we see about 30% discontinue the pump. But again, as I told you before, the motivation is the crucial point. I will go for some videos, so listen to them, please, to have quick summary about the insulin pump.
If you have been diagnosed with type 1 or type 2 diabetes, you can use an insulin pump to control your blood glucose level. An insulin pump is a battery-powered device used to deliver rapid-acting insulin to the body through a catheter, replacing the need for periodic injections. The parts of the device include a battery-powered pump, a disposable reservoir of insulin, and a computer chip programmed to deliver precise dosages. To help maintain a consistent glucose level, you can program the pump ahead of time for continuous insulin delivery 24 hours a day. An insulin pump can help you adjust your blood sugar immediately. You can also program the pump to deliver larger bolus doses of insulin right before eating to accommodate or cover the amount of carbohydrates you are about to eat. Once you have determined your glucose level with a glucose meter, you can program your pump to send the correct amount of insulin into your body. Insulin travels from the pump through an infusion set, including a flexible tube attached to a soft plastic cannula inserted just under the skin. Using an insulin pump may help you lead a more flexible lifestyle while helping you maintain a more consistently stable glucose level. Studies show that regular monitoring and maintenance of glucose levels help prevent long-term diabetic complications such as blindness, kidney disease, heart disease, and stroke.
Hello and welcome to the Insulin Pump and Continuous Glucose Monitor information session brought to you by the Certified Diabetes Care and Education Specialists at The Ohio State University Wexner Medical Center. We will be reviewing all of the FDA-approved continuous glucose monitors and insulin pumps that are currently on the market. We will then discuss the protocol at Ohio State and what the next steps are in obtaining the technology. Please note that there is a link on the website to a short survey for you to complete at the end of the session. This will allow you to communicate your device preferences with the education team. We will first cover the continuous glucose monitors. I often refer to these as CGMs for short. We will talk about what they are, how they work, and the specific options that are currently available. There are three main parts to the CGM system. The sensor is the piece that is placed directly under the skin and held in place by an adhesive patch. The transmitter wirelessly sends the glucose reading to the receiver. Lastly, the receiver, which may also be your smartphone if you have compatibility with the app, will display your sensor glucose data. The sensor is measuring the interstitial glucose level, which is the glucose that is found in the fluid between the cells. Due to this, the sensor data can be approximately 5 to 10 minutes behind the actual blood glucose level. CGMs can be used alone or with an insulin pump. They continuously monitor sensor glucose 24 hours a day and update readings every 1 to 5 minutes. Not only does it provide a sensor glucose value, but it will also show you the speed and direction that your glucose is headed. Another helpful tool is the optional alert feature. Most sensors have high and low alerts that you can set, which can be individualized for you. You may also choose to have alerts when your glucose is rising or falling rapidly. Some CGMs that are connected with an insulin pump can temporarily suspend your insulin when you are predicted to have a low blood sugar, as well as automatically adjust your insulin delivery based on the predicted sensor glucose changes. We will talk about that in more detail when we get to the insulin pump specifics. There are many advantages of CGM therapy. It provides more than just a static number. It also provides the trend information in real time so you know where you are headed. With this glucose trend information, you are in a better position to make an informed choice on what to do about your current glucose level. By having personalized alerts, it can help you detect low blood sugar that you may not feel coming. It can also help you catch the highs that you may have otherwise missed. Some of the CGMs allow for the user to share glucose information, including alerts, with friends and family members. CGM data gives the user a visual representation of their patterns on a daily basis. This helps to assess the effectiveness of your current insulin doses, as well as the effects of food and exercise on glucose levels. As previously mentioned, CGMs can be combined with certain insulin pumps, but can also be an extremely effective tool to use on its own. Despite the many benefits, technology can have some drawbacks. There is an upfront cost for the CGM system, as well as the ongoing cost of supplies. It does not entirely replace finger sticks, although it can significantly reduce the frequency of them. Some CGMs do require calibration. Calibration is the process of entering a blood glucose reading from your meter to calculate the sensor glucose values. Finger sticks are recommended anytime your symptoms do not match your sensor glucose reading. Due to this, you do want to make sure you still have your glucose meter and your test strips. Some people experience skin sensitivities from the adhesive tape. However, there are many products out there that you can use on your skin to prevent or alleviate this. A sensor is something that's worn on the body. If you are wearing both a pump and a CGM, that is 2 insertion sites to get used to and 2 site changes to keep up with. Lastly, CGMs provide a lot of data, so it is possible to feel overwhelmed. Sometimes it may feel like there are too many numbers to know what to do with. A training with a diabetes care and education specialist is essential in helping you better understand how to use your system, interpret the data, and make appropriate treatment decisions. There are 4 CGMs that are currently available. They are the Dexcom G6, the Eversense, the Freestyle Libre, and the Medtronic Guardian Connect. The Dexcom G6 sensor is changed once every 10 days, and the transmitter is changed once every 3 months. A one-touch applicator is used to easily insert the sensor just beneath the skin. It is approved to be worn on the abdomen for anyone above the age of 2. There are no calibrations required from the user. The sensor glucose values are updated every 5 minutes. You can also share your data with up to 10 different followers. Using Dexcom Clarity, you can review your own glucose reports and share your information directly with your diabetes care team. You may choose to receive your data using the handheld receiver, or if you have a compatible smart device, you can download the app and have your information sent directly to your phone using Bluetooth without the need for a receiver. If you use the phone and also have a smartwatch, that is an additional avenue to receive your glucose information. The Eversense is a 90-day system that is professionally placed under the skin by a healthcare provider. It is inserted into the upper arm. Real-time glucose data is received using the mobile app. The sensor provides on-body alerts from the transmitter even when your mobile device is not nearby. The transmitter can be removed without wasting the sensor. It does get removed once daily to charge, and it is reusable for up to 1 year. Sensor glucose values are updated every 5 minutes, and 2 finger sticks are needed each day for calibration. After the sensor is placed, it does take 24 hours to warm up before you start to receive glucose data. Your healthcare provider will remove and replace your sensor for you in the clinic every 90 days. The Freestyle Libre currently has 2 products, the Libre 14-day system and the Libre 2. For both systems, the sensor is changed once every 2 weeks. It is worn on the back of the upper arm and is the size of 2 stacked quarters. For the 14-day system, data can be received using the handheld reader or the Libre app on your phone. The Libre 2 does not currently have an app to use. Instead, you would use the handheld reader. When using the app for the 14-day system, you can share data with up to 20 followers. There are no calibrations required, and the sensor glucose value is displayed with a 1-second scan using either your phone or the reader. One additional and important difference between the two systems is that the 14-day system does not have optional high and low glucose alerts, and the Libre 2 does. The Medtronic Guardian Connect is the last standalone sensor. Current glucose levels and trends are seen using the app on your mobile device. There are optional alerts, including predictive alerts up to 60 minutes in advance of a high or a low glucose event. The sensor is approved for use on the back of the upper arm or the abdomen. It comes with a one-press inserter for insertion. The sensor is changed out every 7 days. The transmitter is reusable for up to 1 year. The system requires a calibration from the user, a minimum of once every 12 hours. Data can be shared with up to 5 people. The Sugar IQ Diabetes Assistant app works with the Guardian Connect and can help the user identify patterns and understand trends. The transmitter that is used for this Medtronic standalone CGM is different than the transmitter that is used for the CGM that connects with the Medtronic pumps. We will now switch gears to insulin pumps. We will discuss the basics of insulin pump therapy, and will then review in detail each of the options that are available. An insulin pump is a small mechanical device that continuously delivers insulin through a small cannula placed under the skin. It is designed to mimic the way that a pancreas delivers insulin, and this is done in 2 ways. Bolus insulin is the amount taken for food as well as correction. Basal insulin is your background coverage that is delivered in small amounts every couple of minutes to help keep glucose constant in between meals and overnight. You will use rapid-acting insulin only in an insulin pump, and this insulin is programmed to be delivered in these 2 different ways. Pump supplies will consist of the actual pump itself, the part that holds insulin, which is called the reservoir, the cartridge, or the pod, depending on which pump you have. The infusion set consists of the tubing that carries the insulin to the body, as well as the cannula that's in place under the skin. The tubing is easily disconnected from the site on the body for situations such as bathing or swimming. Lastly, you will still have a blood glucose meter. Some meters can be connected to the pump, so your blood sugar results can be transferred automatically. As we discussed with CGMs, most devices come with both advantages and disadvantages. For the advantages first, pumps allow for very precise insulin delivery. If you are coming from injections, you are used to giving whole units of insulin at a time. Pumps can provide very small fractions of a unit that can make a big difference for those who are particularly sensitive to insulin. People tend to enjoy the freedom from injections, no longer having to stick themselves multiple times a day. All pumps have built-in calculators. When you enter the carbohydrates that you plan to eat and your blood glucose level, the pump calculates your insulin dose based on your program settings and any insulin you may already have working in the body from a previous dose. Another advantage is being able to set temporary increases or decreases to your basal rates. This may come in handy for exercise or sickness when you temporarily need more or less insulin. Pumps allow for flexibility and convenience. Adjustments can be made easily to accommodate the normal changes in your daily life. Each pump comes with a free software that is used for data collection and analysis to assist in making adjustments to your treatment plan. A pump eliminates the unpredictable effects of long-acting insulin. Pumps use rapid-acting insulin only that has a more efficient and predictable action time. Overall, having a pump may lead to improved A1Cs, reduction in glucose variability, and ultimately an improved quality of life. Moving now to some of the disadvantages, one of which is cost. Insulin pumps are more expensive than syringes and pens. Although most insurance plans cover insulin pumps and supplies, there are often copays and deductibles they take care of. There is a higher risk of developing diabetic ketoacidosis if the pump malfunctions, since you use rapid-acting insulin only. Being attached. Since the pumps need to be worn all the time, it can become an issue during certain activities when you may prefer that something not be attached to your body. Skin issues. It's possible to have skin sensitivities to the adhesive tapes and develop scar tissue where the cannula is inserted if you do not rotate your sites well enough. It is possible for the user to feel overwhelmed at first. There is a steep learning curve, and it may take some time for the user to get used to changing infusion sets, being attached to the device, and regulating your settings. There are 3 pumps that are currently on the market. They are the Omnipod, the Medtronic, and the Tandem t:slim. The Medtronic 770G is the newest pump available from Medtronic. It is a hybrid closed-loop system, meaning that it will automatically adjust the basal insulin delivery every 5 minutes based on the sensor glucose values. This pump works with the Medtronic Guardian CGM. It is important for people to know who have Medicare that the 770 pump is covered, but the compatible Guardian CGM is not. The 770G transmits data to your smartphone, allowing you to view the CGM and insulin data without taking the pump out. You may also have up to 5 followers who can receive this information in addition to your high and your low CGM alerts. The Bluetooth connectivity enables automatic pump uploads to your diabetes care team. The Medtronic 630G is another option. It does look very similar to the 770 pump. However, it is not a closed-loop system where the pump automatically adjusts the basal insulin delivery. This pump is covered by users with type 2 diabetes who have a commercial insurance plan. The 630G pump does have the ability to suspend the insulin delivery in advance of a predicted low blood sugar when using the Medtronic sensor. The Medtronic pumps link with the Bayer Contour meter. Using this meter, the glucose result will be sent automatically to the pump. The smallest increment of insulin it provides is 0.025 units per hour, and it holds up to 300 units of insulin. The Omnipod is the only tubeless pump option. It is completely waterproof and is held on the skin by a durable adhesive backing. All pump activity and adjustments are done through the handheld device, which is called the Personal Diabetes Manager, or PDM for short. Right now, there are 2 options for the Omnipod system, the Classic and the Dash. The system received will entirely depend on the user's insurance coverage and patient preference. The main difference between the 2 systems is the PDM. The Dash PDM is a lightweight touchscreen device that will connect with an app called the Omnipod Display. This app allows you to see your insulin on board, your last bolus, last blood glucose reading, and more without having to pick up your PDM. There is also an Omnipod View app, which allows family members and caregivers to view the PDM data from afar. The Classic PDM uses 2 AAA batteries, while the Dash is rechargeable using the USB cord. The Classic PDM has a built-in freestyle glucose meter, and the Dash links with the Contour Next meter. The smallest amount of insulin that the Omnipod provides is 0.05 units per hour. It takes a minimum of 85 units and a maximum of 200 units per pod. The cannula inserts automatically by a press of a button on the PDM. This pump does not currently have a connection with a CGM, but they are hoping for FDA approval for a closed-loop system with the Dexcom in 2021. The third and final pump is the Tandem t:slim. Their newest Control-IQ system is an advanced hybrid closed-loop system that pairs with the Dexcom G6, requiring 0 finger sticks. This system predicts sensor glucose values 30 minutes in the future and will adjust the basal insulin delivery up or down based on these predictions. It will automatically suspend insulin delivery if the sensor glucose value is predicted to be less than 70 in the next 30 minutes. Automated correction boluses are also given if the predicted values are to be greater than 180. The system targets a glucose value of 110. Basal IQ is an additional software option. This system also uses the Dexcom G6, and it will suspend the insulin delivery 30 minutes in advance when sensor glucose is predicted to be less than 80. It does not automatically adjust the basal delivery. The system is most suitable for those using concentrated insulins, such as U500, those who require less than 10 units of insulin a day, or those who may not want a pump that automatically adjusts the insulin delivery, but would like to have the insulin suspension only to help prevent the lows. The newest t:slim pumps can be paired with the t:connect mobile app, which enables automatic uploads to the diabetes care team. The t:slim is rechargeable using the USB cord provided. It is touchscreen. It has the smallest increment of insulin at 0.001 units per hour. The cartridge holds a minimum of 85 units and a maximum of 300. Lastly, Tandem allows its users to remotely complete any software updates that may come along while the pump is in warranty. That way, you do not have to wait until the warranty is up to get the latest improvements. For those who may not be ready or interested in an insulin pump, there are some other technologies that are available. The InPen is the only FDA-approved smart insulin pen that combines a reusable Bluetooth-enabled insulin pen and a mobile app. Based on the settings that you have programmed, which include your insulin to carb ratio, your correction factor, blood sugar target, and active insulin time, you will receive personalized insulin recommendations right from your app. It will calculate for you how much insulin you need for food and correction while keeping track of all insulin previously taken to avoid insulin stacking. The InPen system offers a series of customizable reminders. The InPen delivers half-unit doses. It's compatible with refillable cartridges of Humalog, Novolog, or Fiasp, and it can sync with your continuous glucose monitor or blood glucose meter. The V-Go is an all-in-one insulin delivery system that is applied like a patch and is most often used in people with type 2 diabetes. Designed to replace both your long-acting insulin and your multiple mealtime injections, V-Go delivers a continuous basal insulin rate over 24 hours, in addition to on-demand dosing at meal times in increments of 2 units. The V-Go uses an adhesive to stay on the skin. It is completely waterproof and is changed out every 24 hours. They do come in 3 different sizes, the 20, the 30, and the 40, to match the amount of basal insulin that is needed by the user. Our protocol at Ohio State is developed to ensure that you are equipped with the best possible self-management skills to be successful long-term on whatever device you choose. After completing this info session, the next step is to attend one of our 2-part virtual diabetes education classes if you are pursuing an insulin pump and have not had any education with our team in recent years.
Okay, we are done here with this video. I hope that it was a good review for the types of insulin pump, CGM available in the market. Maybe it's the time now, before going to the break, to have 2 or 3 clinical scenarios are per agenda. I will not take a long time, just a quick review for some of the clinical scenarios for the patients with type about initiation and intensification of insulin in type 2 patients. It needs your quick answers. I will go for the first scenario, then not more than 5 minutes, inshallah, we can conclude and go for the break. The first scenario here is a 76-year-old female, non-type 2 diabetes mellitus, multiple episode of early morning hypoglycemia. She had an attack while go to the bathroom that caused her to fall and fracture. She is on Humalog, mixed 25%, using 20 units BID. Self-monitoring blood glucose, fasting between 70 and 150, postprandial between 50 up to 250. A1C is 8. What is the next appropriate step? Do you think A, change to oral metformin, sitagliptin and sitagliptin, B, change to insulin glargine and insulin lispro, C, decrease both doses by 10%, D, increase her caloric intake? Please, I need your input in the chat box. Then I will explain to you what is the idea behind this question. C, change to insulin glargine. What else? Any other opinion? I will give you a few seconds more to think about proper answer in this practical scenario about type 2 diabetes patient who is on using BID dose of mixed insulin, and due to hypoglycemia, there are many choices in front of you: either decrease the doses, either to go for basal bolus, or go back to the regimen of oral medication. D and B, we have many choices, but actually the correct answer going with basal bolus, which is B, which is basal bolus. So the proper answer to go with basal bolus, which is choice B. So basal bolus regimen, when dosed properly, reduces the risk of hypoglycemia. Basal like glargine, titimir, and MPH can be used. The optimal basal should be Beclist, as we mentioned before, and you can use the Novorapid to cover the mealtime hyperglycemia. The message here: decreasing the dose of mixed insulin may diminish her overnight hypoglycemia, but causing higher fasting glucose. This is, I mentioned yesterday, because of the no flexibility. The one injection, it contains both components, the fast or rapid acting insulin and the MPH component, so it is not flexible and appropriate in this particular patient. I have this scenario: the patient, the same patient in previous scenario, started on basal insulin, reached to 40 units after titration, comes to you 3 months later with the following blood glucose. Fasting in 130 is 130, post-breakfast 200, post-lunch 295, post-dinner 200, A1C 7.8, and still not controlled. So what to do? Add Lispro 3 times daily before each meal. B, increase basal insulin to 45. C, add Lispro before lunch only. So I need your input here. This is the last question before go for the break. So I need your input. So we have B, and we have also A, and we have C. Any opinions from you? Okay, so here the proper, we can say the best option to go for what we call it basal plus C here. This is from American, which is C, the American Diabetes Association, American Clinical Endocrinology Association. If the patient on basal, you can go for 1 prandial. It is called plus. It means you add 1 prandial with the biggest meal or the largest meal. here in our community, usually the range, if it is not controlled after time, maybe you go up for 2 times preprandial, and if it's not controlled, to go for 3 times full basal bolus. Here, no need to increase the basal insulin because fasting already controlled, but the idea here is to go for basal plus, as it is written here, basal plus 1, and then if it is not controlled, basal plus 2, and if it is not controlled, basal plus 3, which is full basal bolus regimen. By this, I am done with my topics in this course. I hope it was interesting for all of you, and I will go now for the break, and then my colleague, Dr. Hamid Al-Sahafi, will complete the journey today at 7 p.m. So feel free now to go for the break till 7 p.m. نستودعكم الله والسلام عليكم ورحمة الله.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه أجمعين. Dear attendants, you are welcome today for the last session for this very important course about diabetes and diabetes made easy. I will complete the journey as Dr. Bender started today for the last session, last day for this important course. I will concentrate about the new aspect of diabetes with the special situation and diabetes and Ramadan. As we know, diabetes is a chronic disease. A lot of the complications associated with diabetes, as we said before, but diabetic patients, they need special concern about situation, different situation like diabetes and Ramadan, diabetes in elderly, diabetes with exercise. I will concentrate in this lecture about diabetes and Ramadan. As we know, the all Muslim, they have obligate to fast month of Ramadan, except some patients, they are exempted from fasting Ramadan. Those with chronic diseases, with severe disability, they are exempted from fasting Ramadan. But if the patient can be fast, allowed to be fast, he should sit with his doctor to adjust his medication, and the doctor and treating physician and treating team, they will educate the patient in special situation when he break fasting, when how many time he will check the blood sugar during fasting, what the adjustment of the medication need a patient before going to fast a month of Ramadan. As we know, in the first Quran, Allah Azza wa Jal said, يا أيها الذين آمنوا كتب عليكم الصيام كما كتب على الذين من قبلكم لعلكم تتقون. The fasting Ramadan is one of the pillar. It is the fourth pillar of Islam. No Islam accepted without fasting Ramadan. Muslim, they should healthy Muslim, they should fast Ramadan. Healthy adult Muslim, they should fast Ramadan, except if they have any situation like traveling or disease patient, they are exempted from fasting Ramadan. Also, the other religion, they should fast some days of the year, like Jewish, Hindi, Christianity. They fast days from the year. Fasting Ramadan is one of the fifth pillar of the Islam. It's the fourth one, obligate with many exception, like traveling or disease patient. It involves no eating from and drinking between dawn and sunset, including oral medication. All the through oral route is prohibited for during fasting Ramadan. Also, some anal route, it's also break fasting. So there is an intense of desire for all Muslims to fast Ramadan, especially all our patients. They want to fast Ramadan like other community. So there is a lot of risk during fasting Ramadan for our patient, diabetic patient, hypoglycemia, hyperglycemia, dehydration, and diabetic ketoacidosis, especially in patients with type 1 diabetes. As we know, the International Diabetes guidelines, Federation guidelines, fasting in Ramadan guidelines is depend on scoring to know the risk of patient in fasting Ramadan. We should certify our patient to mild, moderate, and risk or high risk patient depend on the score. Depend on the score, which concentrate about the diabetes type, diabetes duration, diabetes with comorbidity, and also the treatment of diabetes, either oral hypoglycemic or insulin, and also about the measuring and monitoring the blood sugar, and also the acute complication for the last 3 months before fasting Ramadan, and also renal and cardiovascular complication associated with the Ramadan, and also special patient like pregnancy, if the patient pregnant or not pregnant, or also the variety of the cognitive function of the patient, physical activity. If the patient doing heavy physical activity, also it had a high score to be counted counted in the estimation of the score, risk score for fasting Ramadan. Also, the experience of the patient for the last year, did he complete the fasting Ramadan or not complete the fasting Ramadan last year, and also the hours of the fasting. If it's more than 16 hours or less than 16 hours, we should take in the consideration. And also it's the scoring. This scoring is present in the application for the and Android mobiles. It's in the form of DAR application, DAR, D-A-R application, to estimate the score of risk of fasting Ramadan. The score, after we collect the score, the patient in the score of 0 to 3, it's patient allowed to fasting Ramadan, low risk. And if the patient gets a score from 3.5 to 6 is moderate risk. And if the patient gets more than 6 or more score, the patient categorized as high risk patient, it's prohibited to fast Ramadan. So what about the type of patients? Type 2 diabetes patient in fasting Ramadan, they have risk for hypoglycemia, 4 to 0.7 fold to increase risk of hypoglycemia, and also during Ramadan, and they have 3.2 fold to have severe hyperglycemia during Ramadan, and also the patient had 7.5 fold to increase risk of severe hypoglycemia during fasting Ramadan, and also they have increased 5-fold to have severe hyperglycemia in type 2 diabetes and also in type 1 diabetes. Type 1 diabetes, they have high risk there compared with the type 2 diabetes. So type 1 diabetes, they have around 4 fold to have severe hypoglycemia. They have at risk for severe hypoglycemia and also severe hyperglycemia ended by diabetic ketoacidosis, while the other type 2 diabetes compared with the type 1, they have lower risk, but still they have high risk for hypoglycemia and hyperglycemia. So the most serious type of diabetes during fasting Ramadan is type 1 diabetes. So Allah Azza wa Jalla قال في سورة البقرة يا أيها الذين آمنوا ومن كان مريضا أو على سفر فعدة من أيام أخرى. If the patient have disease or a patient in traveling and he can allow to break fasting or not fast Ramadan, and he can replace the fasting in the other month if he healthy or he arrives to his category. The patient who had high score 6 or more score is categorized as high risk patient, and patient advised not fasting Ramadan. The fasting Ramadan, it had a high risk for this patient to get a complication during fasting, either hypoglycemia or hyperglycemia. So the scoring is very critical point for educate patients and instruct patients about fasting or not fasting. So not fasting Ramadan for high risk patients who get a score more than six points of the risk categorization of the fasting Ramadan. So a patient with high risk is prohibited to fast Ramadan, advised not fasting, and they should not fast Ramadan. Patient with moderate risk who get a score from 3.5 till 5.9, these individual advise not fasting Ramadan, but if they prefer to fast, they will fast with the instruction, and after sitting with the treating physician and treating team, and the treating team, they will adjust their medication and instruct them how to deal with special situation during fasting, when they break fasting, when they how they adjust the medication, and how they eat the meal during before fasting, and how they break fasting. And also the team also instruct the patient how frequent they measuring the blood sugar. And category 3, the patient with less than 3 points or 3 percentage 3 points of the score, they are counted as low risk patient, and they are allowed to fast Ramadan. So the most important guidelines is DAR guidelines, Diabetes and Ramadan practical guidelines by International Diabetes Federation, the yearly release guidelines, and also there is application about the scoring DAR application for calculation the score of your patient. So you can upload the DAR application for iOS or Android machine to calculate the risk for your patient, and accordingly to advise your patient fasting or not fasting Ramadan. So patient with before Ramadan, we should calculate the risk for categorize patient high risk, moderate risk, or low risk. And when they do the exercising during fasting Ramadan, what about fluid? What about medication adjustment? If the patient advised not fasting, they are very high risk group, or they have high risk group. If the patient also insists to fast, we instruct them not fasting. If they are patient still insisting, we should instruct them when what the adjustment will adjust the medication, and also we instruct them when they fast break fasting if the blood sugar less than 70, if the patient has symptom of hypoglycemia, and if the patient had hyperglycemia with blood sugar, random blood sugar is 300, and if the patient has symptom of hypoglycemia. So this is the important points when they break fasting. The first point is hypoglycemia, measured hypoglycemia less than 70. This is they should break fasting. And if the patient has symptom of hypoglycemia in the form of sweating, blurred vision, or palpitation, they should break fasting. And if they have hyperglycemia symptom like blood sugar more than 300. And if the patient allowed to fasting, we should instruct them to 2 to 3 times measuring the blood sugar during fasting Ramadan. When the patient this is about the point to instruct your patient. Risk qualification, blood sugar monitoring will instruct the patient to frequent blood sugar 4 to 7 times during fasting Ramadan, especially moderate to high risk patients, or the patient mild risk, they should measure the blood sugar 2 to 3 times. And what about the fluid? They should increase fluid intake during the non-fasting hours. during night? And also, what about the exercise? The patient should be instructed not do exercise during fasting Ramadan, during fasting hours, and the patient allowed to exercise after iftar during the night, and also the prayer Taraweeh is counted as exercise for these patients. What about also we should instruct them about the adjustment of the medication. We should decrease the dose of the medication, especially insulin or oral hypoglycemic during Ramadan month. When they break fasting, they should instructed when they break fasting, if the blood sugar less than 70, or they have symptomatic hypoglycemia, or the patient has blood sugar more than 300. Risk categorization, we should calculate the risk before around 1 to 1.5 months before Ramadan. We should risk the patient, sit with the patient, we discuss the risk for fasting, and we should instruct them fasting or not fasting Ramadan, and we should monitor, we should instruct them how frequent they monitor the blood sugar during fasting Ramadan. And also, as I said before, exercise. When they do exercise, we instruct the patient to do exercise in the non-fasting hours. Also, the medication, we should adjust their medication before going fasting Ramadan. As we know, I mentioned before, we should stress that when they break fasting, if the blood sugar less than 70, or the patient has hypoglycemic symptom, or a patient with hyperglycemic symptom and dehydration, and also if the blood sugar more than 300. So the hypoglycemia symptom is sweating, palpitation, hunger, altered level of consciousness, or the hyperglycemia, polyuria, polydipsia, hunger, confusion, nausea, vomiting, and abdominal pain, and the sign of like dehydration and diabetic ketoacidosis. What about the insulin? Insulin, they should adjust insulin if the patient taking 1 daily dosing of insulin, take 1 dose of the insulin. We should decrease the insulin by will take a normal dose of at iftar. If the patient has this is about regular insulin. If the patient has regular insulin once daily, he should take the same dose at iftar. If the patient has long-acting insulin, he should take 2/3 of the dose at night. If the patient, this is about mixed-start insulin. If the patient has a pre-mixed insulin, he will take the same dose at iftar. If the patient has twice daily mixed insulin, he will take the same dose at iftar, but he should take 25 to 50% of the sahur dose. So this is about pre-mixed insulin. If the patient take 1 dose of the pre-mixed before once daily, he will take the same dose at iftar and during fasting Ramadan. But if the patient has twice daily pre-mixed insulin, he should take the same dose at iftar, but in sahur dose, he should take 25 or 50% of the dinner dose at sahur time. If the patient has 3 times pre-mixed insulin, he will take the breakfast dose at iftar time before the iftar, but he should omit the lunch dose of the pre-mixed insulin, and he will take 25 to 50% of the dinner dose at sahur time. And he will adjust the sahur before the sahur dose before breakfasting, and he will adjust the dinner, the sahur, the iftar dose according to the pre-sahur dose, pre-sahur reading. So what about the MDI? If the patient has multiple daily injection of insulin, he take 1 dose of the one dose of insulin, basal insulin like glargine, and take regular insulin, ultra short insulin before each meal. He will, if the patient has NPH or Detamir or glargine or Digludac once daily, he will reduce 15 to 30% of the dose, and he will take it at iftar time. And if the patient has NPH or Detamir or glargine twice daily, he will take the same dose at iftar, but he will reduce the second dose 50% of the basal insulin at sahur time. What about the short-acting insulin? He will take the normal dose at iftar, but he will omit the lunch dose, and he will take 50%, 25 to 50% of dinner dose at sahur. So if this is a patient taking multiple daily injections of insulin, the glargine, it will be decreased by 25%, and he will take it after iftar. And if the patient has short-acting insulin before each meal 3 times daily, he will take the iftar dose same, but he will omit the lunch dose, and he will take the dinner dose at sahur, and he will take only 25 to 50% of the dinner dose. This is about premix, we mentioned before. If the patient, what are the changes of the insulin pump? If the patient taking insulin pump, will reduce the basal rate by 20 to 40% at fasting, 3 to 4 hours of the last fasting hours, to avoid hypoglycemia, and will increase 30% of the after iftar the basal rate by 30%. What about boluses rate? Normal carbohydrate counting and insulin sensitivity principle apply to the same like before Ramadan. So the basal rate will decrease for the 4 last hours from fasting, and will increase by 30% after iftar, and will keep the boluses and count carbohydrate counting and insulin sensitivity. I want to stress when they break fasting, glucose, if the blood glucose less than 70 milligram, hypoglycemia, or a patient has a hyperglycemia 300, more than 300 milligram per deciliter, or the patient has symptomatic hypo or hyperglycemia, or a patient with severe dehydration. So also when they recommend to the blood sugar monitoring before, it's around 7 times during fasting Ramadan, before also before at sahur time, and also at midday, and around morning, and also in midday, and also before iftar, and also at iftar, and in the evening he should monitor the blood sugar. Pre-dawn, and morning, midday, mid-afternoon, also pre-sunset, pre-iftar, and 2 hours after iftar. At any time, patient would have symptom of hypo or hyperglycemia. So also I stress on insulin, but we should mention how we adjust the oral hypoglycemic. The oral hypoglycemic depend on the group of oral hypoglycemic. If the patient taking metformin, the patient take the same dose during, and if the patient had sulfonylurea, and the patient taking sulfonylurea once daily, he should decrease by 30% of the dose. And if the patient has sulfonylurea taking 2 times, he will take the same dose at iftar, and he will take 50% of the dose at sahur time. What about DDP4 inhibitor like Januvia or sitagliptin, linagliptin, or vildagliptin? He will take the same dose, no adjustment during fasting Ramadan. What about SGLT2 inhibitor? He will take the same dose before Ramadan and during fasting Ramadan. What about the bioglitazone during fasting Ramadan? No dose adjustment of the bioglitazone during fasting Ramadan. So the adjustment usually for insulin and sulfonylurea. Sulfonylurea because the risk of hypoglycemia, and also for insulin because it causes hypoglycemia. It would decrease in general insulin dose, especially basal insulin, and the insulin taking the regular insulin before sahur time because the patient is going for fasting, or if the patient has sulfonylurea, we should decrease the dose of sulfonylurea, especially patient with control blood sugar before fasting Ramadan. If the patient has controlled hemoglobin A1C, he is liable to go for hypoglycemia during fasting Ramadan. So we adjust the basal insulin, we adjust the regular insulin or ultra short insulin before sahur time, and also will decrease the dose of the sulfonylurea in the month of Ramadan because we'll avoid the hypoglycemia during fasting Ramadan. This is the most important things. I want to stress on the risk certification for your patient when they not advise not fasting Ramadan, and when they fast Ramadan, when they should break fasting, and when they how many frequent blood sugar monitoring during fasting Ramadan, and also when they should to advise the measuring the blood sugar during fasting hours, and also when they exercise, when they do exercise, they should instructed to do exercise in the non-fasting hours and after iftar time. And they should instructed to take a lot of fluid during non-fasting hours. Thank you. And also, I want to continue to the second lecture today. If you have question, I will answer before going. Yes. Maimuna, she asked about a very interesting question about what the name of the score. Score is DAR guideline score, DAR. I will type the answer. I will put it in the chart and chat DAR. The application presented in the DAR. DAR application is I put it in the chat. DAR application, it's how to calculate the risk of fasting Ramadan for your patient according to International Diabetes Federation about fasting Ramadan, and every year they update the guidelines, and also it's presented. If you want to go through the all guidelines, it's presented in the Google Google website and DAR guidelines. DAR guidelines. I will write it in the chat. DAR guideline. Fasting Ramadan. And the application is in the iOS and also in Android, DAR application. I will see the second lecture. I will go for the second lecture. I will go for the second lecture about the initiation and intensification of the insulin in type 1 diabetes, and we'll go for some cases. I want to be interactive. If you are interested to answer, you are more welcome, and put the answer in the chat. I will go for general idea about insulin therapy during the type 1 for type 1 diabetic patient. Type 1 diabetes patient, the very high risk patient. The most important for them is insulin therapy, as I mentioned before. No treatment except insulin for this type of patient. The preferred regimen of this patient is basal bolus insulin regimen. It's preferable regimen for this type of patients. We'll give 1 dose of basal insulin to cover the requirement of basal requirement of insulin for 24 hours. Then we'll give the bolus insulin before each meal, and this is for very flexible regimen, and the patient is not must to take food to cover the insulin dose. If he want to eat, he will inject his insulin. If he didn't want to eat, he will not take the insulin, the regular insulin or ultra short insulin before meal. So this is the most flexible regimen for our type of patients. This is the most the study shows it's most regimen to control the blood sugar compared with the premix insulin. And this is the regimen. It's low risk for developing the diabetic ketoacidosis compared with the other regimen like premix insulin twice daily. Twice daily insulin is very dangerous for this patient. If he delay to take the second dose, he will go for diabetic ketoacidosis. So the most common regimen is the basal bolus. Will give glargine or glargine 300 or Tresiba like Degludec insulin as once daily insulin. Basaglar is glargine 100. It will give 1 dose at bedtime, and will give the other ultra short insulin like Lispro or Aspart or Glurozine before each meal, breakfast, lunch, and dinner, and we'll adjust the dose according to the guidelines, fasting blood sugar and 2 hours post blood sugar, as we mentioned before. What the site, Dr. Bender, he mentioned about the site of insulin injection. We prefer, as Dr. Bender said today, we should rotate the injection of insulin by weekly basis. We'll use the arm and also the thighs, and also we should use the abdomen and change the insulin injection to avoid any side effect of insulin injection like lipodystrophy. We'll start with the real case. How you start insulin for 1 patient type 1 diabetes, 23 years, female, type 1 diabetes, newly discovered diabetes type 1, presented with hyperglycemia, RBS, random blood sugar is 250, and hemoglobin A1C is very high, 10 hemoglobin A1C, and body weight for 48. Usually, we will start Lantus, 12 units PM, and Bidra or ultra short insulin 4 units before each meal. How we calculate this dose? Patient weighing will calculate the dose, total daily dose of insulin. It's counted as 0.5 by patient weight. Patient weight is 48, multiplied by 0.5, it's 24. So the total daily dose for this patient is 24. 24 will give 40 to 50% of the dose as basal insulin, as glargine, and will give the other 40 to 60% of the dose as boluses, and the boluses divided by 3 to give before each meal. So the total daily dose is 24, so 50% of 24 is 12. So we'll give the 12 units before as basal insulin, as glargine at bedtime, and we'll give the other 50% of the other 50% is 12 divided by 3. It's equal to 4 units before each meal. So this the end result of the dose is glargine 12 units at bedtime, and we'll give Lispro or aspart insulin and glulazine 4 units before each meal. So the corrective dose. What about the corrective dose? This patient, this is how we dose for a patient with high blood sugar and blood sugar shooting. If the patient has taken 6 units per day, this is the total daily dose of insulin, and this is the blood sugar. We should, as we know, we should calculate the insulin sensitivity to know how many units of insulin to decrease the blood sugar to the target. So the insulin sensitivity, we should calculate the insulin sensitivity. This is a fixed figure, 1,500 divided by total daily dose. Total daily dose for this patient is 60 units. So the total daily dose divided by the 1,500 divided by total daily dose. So the total daily dose, this patient is taking 36 plus 21, 36 Lantus, and he will take, the patient took 21, 7 units before each meal, so 21. So the equal dose of the patient is 60 units as mentioned above. So how we calculate the insulin sensitivity? Insulin sensitivity 1,500 divided by total daily dose. The patient sensitivity is 25. It means every 25 milligram per deciliter blood sugar need 1 unit to decrease it. So the patient extra, we should calculate the extra blood sugar. What's the target blood sugar? Target blood sugar, as we know, we want to decrease it to 150. So we should calculate the excess blood sugar for this patient. The excess blood sugar calculated as 425. This is the blood sugar, and minus our target blood sugar, which we want to decrease it, 150. So the extra blood sugar is 275. So the excess blood sugar is 275 divided by the insulin sensitivity will give us 11. So 11 units of insulin, ultra short insulin, it's enough to decrease the blood sugar from 425 to the target 150. This is how we correct the blood sugar when the blood sugar shooting for these type of patients. So the 2 primary techniques available for health provider and patient to assess effectiveness and management of plan for glycemic control. Patient blood sugar, the fasting blood sugar is less than from 75 to 130, and hemoglobin A1C should be less than 7 for all type of patients. And according to your patient, you will adjust your blood sugar. Most patients with multiple daily injection of insulin pump therapy should do the self-monitoring blood glucose before meal and fasting, at bedtime, exercise and after exercise, and after treating with low glucose until they are normoglycemic, and period to critical tasks such as diving, and occasionally if the postprandial and if the patient is symptomatic. What is the checking? Why is checking important? We should know the target blood sugar. So before meal and fasting, the blood sugar should be in the target 80 to 130, and less than 180 before 2 hours from after meal, and 90 to 150 before getting sleep. And talk to your doctor or about your goals. So the patient should know their goals when they are above or below the target level. How often we blood sugar checking type 1 diabetes, because they have high risk before meals and bedtime, and every day 6 to 10 times per day to monitor the blood sugar. And better for these patients with frequent hypoglycemia, they use continuous glucose monitoring. Also, period to exercise, and if the patient has hypo or hyperglycemia symptoms. We'll start with the case discussion. This patient is around Nadia. She is 22 years old female, while newly diagnosed type 1 diabetes. Her hemoglobin A1C 7.9, so she is not in the target less than 7. She had blood sugar. She is using Lispro, ultra short insulin, 4 units before breakfast, 5 units before lunch, and she take also 5 units before dinner, and she is taking Glargine long-acting insulin 15 units. So in this patient had breakfast, she had hypo in breakfast 70 and 69, and she has a pre-lunch 59, 45. Post lunch, she had shooting the blood sugar to 245. One reading. We have 2 readings, 1 reading normal and 1 reading abnormal. And before dinner, she had almost normal reading, and also at bedtime, she had a normal reading. What we'll do for this patient, as the patient has, she is taking multiple daily injection of insulin. She had a patient with taking Glargine and pre-dinner, pre-meal insulin. So the insulin regimen in type 1, as before I said, the action, the answer will decrease the Lispro dose 3 units before breakfast and 5 units before lunch and before dinner, and will decrease the Glargine units at bedtime. Because the patient has hypoglycemia fasting, it's related to the Glargine. Patient taking Glargine 15 units, so we should decrease the Glargine to prevent the patient with correct the hypoglycemia for fasting hypoglycemia. This patient had hypoglycemia due to high dose of insulin, of Glargine insulin, so we decrease the glucose. We should decrease the Glargine from 15 to 13, 2 units. And also the patient has hypoglycemia before lunch. It's related to the breakfast dose. Patient taking Lispro 5 units, so we decrease by 2 units. After lunch, the patient has normal blood sugar, except 1 reading. One reading is not countable. And the patient has normal post dinner, so will not adjust the dose of the dinner. So the adjustment decrease the Glargine dose by 2 units because the patient has hypoglycemia at fasting, and also the patient will decrease the breakfast dose because the patient has post breakfast and lunch reading is in the lower side. Case number 2. This patient, 30 years old female, newly discovered diabetes, presented with hyperglycemia, RBS 250, and hemoglobin A1C is high, and she has anti-GAD, positive anti-glutamic acid decarboxylase, indicate the patient has type 1 diabetes, and her weight is 48 kg. What the dose of insulin you will discharge a patient on what dose? As we mentioned before, how to calculate the blood sugar dose will go for 0.5 per kg. What do you think? What do you think? Can you answer in the chat what the dose of the patient will discharge on? How to calculate the blood sugar for type 1 diabetes as a first time to discharge a patient on multiple daily injection? I will see your opinion. Lantus 18 units and Lispro 2 units before each meal, or Lantus 12 units BM or Lispro 4 units before each meal, or Lantus 15 units and Lispro for 3 units before each meal, or Nofo mix or homolog mix. Which regimen you want to discharge this patient? Okay. 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 I will let you for 1 minute to see. Okay. Okay. I think a lot of you, around 50% of you, chose the B, and another 40% chose C, and around 10% chose 1. The answer is, because 0.5 by 48 is 24. 24 will give 50% as basal. 50% of 24 is 12. So B, the right answer. And we'll give the other 50% divided by 3. 12 divided by 3 is 4 units. So the answer B. This is how we calculate 0.5. 0.5 from 24 by 48 is 24. 24 is 50% as basal. This is glargine. And the other 12 divided by 3, it equal to 4 units before each meal. So who chose B? This is the right answer. Case number 3. As we know, this patient is type 1 diabetes. Her taking this glargine and novorapid 7 units before each meal, and she had hemoglobin A1C 9, and 2 hours post prandial she had shooting the blood sugar 425 with negative serum ketones, because any type 1 diabetes she should exclude any diabetic ketoacidosis by measuring the urine ketones, because the blood sugar is shooting. You want to correct, and the patient relative, our patient mother, ask you how many units of insulin I will give to correct the blood sugar to 150. So what the dose of correction of the insulin, how many units will instruct this patient to give her daughter to decrease the blood sugar from 425 to 150. We mentioned before we should calculate the insulin sensitivity. Then we should know the insulin sensitivity for this patient to calculate the target blood sugar excess RBS. Then we'll divide the excess glucose divided by the insulin sensitivity, and we'll get the result. What do you think? A, B, C, D, or E? Can you see your result in the chat, please? Okay. 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 MashaAllah. Yani a lot of you, around 75 of you choose the right answer. The right answer is A. Who chose A? This is the right. How we calculate it? Again, insensitivity sensitivity for this patient is 1,500 divided by total daily dose. Patient taking glargine 39 plus the 21, 7 units before each meal, the total daily dose is 60. So 1,500 divided by 60 units, it's equal 25. This patient insulin sensitivity is 25. So we should calculate, after we calculate the insulin sensitivity, we'll calculate the excess glucose. The excess glucose is the reading of the blood sugars 425 minus our target. We want to decrease the blood sugar from 400 to 25 to 150. So the excess blood sugar is 275. We'll divide the excess blood sugar by the insulin sensitivity. It will give us how much the insulin will give. This is equal to 11 units of ultra-short insulin to correct the blood sugar from 225 to 150. This is how we calculate, and I advise you to picture the screenshot for how to calculate the insulin sensitivity and how to correct the blood sugar from one reading to target blood sugar, and how many insulin you will give. Case number 4, this patient is 23 years old female patient, man, type 1 diabetes, has been taking insulin for the last 2 years, presented with uncontrolled blood sugar, glucose level dramatically increased in the insulin dose during the past 5 months without any apparent cause. This patient is controlled in the blood sugar and his regimen, but suddenly the patient lost the control for the last 5 years with no clear cause. But when we examine it, we find this finding: this depression of the skin in the injection site. So about the question about this depression of the skin at the insulin injection sites. All about this problem except the medical condition characterized by abnormal degenerative condition of the body adipose tissue. This abnormality can be a lump, small, dented the skin, and the form when the person perform injection repeatedly in the same points, in the same spots. This results from repeated injection of insulin in the same spots. This type of lesion are harmless, can be avoided by changing and rotating the insulin injection sites. During the using the verified insulin may be the cause of this depression. Better to use a mixed insulin to avoid this depression or this abnormality. The above lesion can be resolved with IV treatment. So think about this lesion, what we call it, this lesion, and what the wrong statement. I want the wrong statement. 4 of the statements as right, but the wrong statement will we want to the wrong statement about this abnormality. Can you put your answer in the chat? I will see your answer. The wrong statement, a lot of you chose B or C, some of you chose D. Okay. The wrong statement is D. Who chose D? This is the wrong statement. This is lipodystrophy. It's happened or resulted from repeated injection of insulin. We advise, as mentioned by Dr. Bender today, and also I remind you about the injection site. We should avoid it because developing this abnormality is called lipodystrophy. Lipodystrophy is secondary to the repeated injection of insulin in the same site when not rotating. This is the result. This is called lipodystrophy. Lipodystrophy point is it cannot absorb insulin, so the patient loses the control of insulin of blood sugar because the patient repeated in the same side. So this skin is not absorbing insulin well, so the patient will lose the control of the blood sugar. So this patient advised to repeat changing the insulin sites to avoid this abnormality. It's common with the mixed insulin, not verified insulin. So using the clear insulin or ultra short insulin or glargine insulin is better than using the premixed insulin, which contain turbid insulin. So turbid insulin is causing more risk to cause lipodystrophy compared with the verified insulin. So verified insulin less likely to cause this abnormality. Lipodystrophy can be happened with the treatment of the HIV because it's a common abnormality with HIV treatment. So the wrong statement is D. Case number 5, 21-year-old male patient known type 1 diabetes for the last 10 years on Basaglar or Glargine to 20 units and Lispro 8 units before each meal, 8 units, 10 units, and 9 units, presented in the diabetic clinic with history of frequent hypoglycemia. So this patient type 1 presented with in multiple injection of insulin, multiple basal bolus regimen, presented with multiple frequent attack of hypoglycemia. During sleep and without any warning symptoms. So a patient, because he had frequent hypoglycemia, he lost the warning symptom of hypoglycemia in the palpitation, sweating. So he lost his warning symptom of hypoglycemia. No history of decrease or oral intake, no history of increased insulin. So the patient not increased his dose, no wrong doses, and he didn't decrease his oral intake. All about the condition, all about we call this hypoglycemia unawareness, not no awareness sign of hypoglycemia. All true except we want the wrong statement about hypoglycemia unawareness. He didn't need urgent neurology referral to help him to feel of hypoglycemia. B, 2 to 3 weeks period of avoidance of hypoglycemia is advisable since that often restore his awarenessness. C, decrease glycemic hemoglobin target less than 7 will help him to restore his awareness of hypoglycemia. D, insulin pump will help him to determine or decrease the insulin doses. If the decrease of the insulin doses not work in the basal bolus regimen. Which statement is wrong in this about hypoglycemia unawareness? Can I see your input, please? ما شاء الله يعني I think a lot of you chose the right choice or wrong statement. The wrong statement is C. So C, this is the choice, the right choice, but the wrong statement. We want a wrong statement about hypoglycemia unawareness. If you decrease your target hemoglobin A1C less than 7, the patient will go for more hypoglycemia. So these patients with frequent hypoglycemia and hypoglycemia unawareness advised to increase their target hemoglobin A1C target. So the hemoglobin A1C target should be more or more than 7 up to 8. So the American Diabetic Association guidelines advice for this type of patient will increase the target to 8. So we instruct the patient the target fasting till 150 and target 2 hours postprandial till 200 to avoid any attack of hypoglycemia by decreasing the dose of insulin. So if the patient avoid the hypoglycemia attack for 3 to 4 weeks, he will retain his warning symptom of hypoglycemia. So the patient will improve the symptom and the patient awake from this warning symptom, and patient avoid to go more severe hypoglycemia. If the patient lost his warning symptom from hypoglycemia, he will go deep hypoglycemia without any warning symptom. This is very dangerous for our type 1 diabetic patients. Insulin pump is very important for these type of patients. It's highly indicated for those type of patients because we'll give small or doses of insulin, and there is one mode of the insulin pump. It stop automatically if the feel the patient going for the hypoglycemia in next hours. So this is most protective method for these type of patients to go for deep hypoglycemia rather than to give one fixed insulin and one not adjusted later. Hypoglycemia unawareness is about 2 to 3 period weeks avoidance of the hypoglycemia will retain the patient his liability or his perception of the hypoglycemia, and we should advise their patient, as we mentioned before, to increase the target hemoglobin A1C and the target self-monitoring blood glucose. We relax our target to avoid hypoglycemia. So the hypoglycemia symptom, as we know, sweatiness, dizziness, anxious, and hunger. This is sweating. This is the warning symptom. Usually, if the patient feel hypoglycemic, he will know this is symptom of hypoglycemia. He will go directly to simple sugar to correct the hypoglycemia. But if the patient lost his warning symptom, he will go for deep hypoglycemia without any warning symptom. This patient advised to decrease their doses, and we increase our target. This patient, if the patient awake, he will take the, as we mentioned before, the target, the hypoglycemia usually symptoms started from 70 milligram per deciliter. If the blood sugar go down than 70 milligram, the patient start to have sweating and palpitation. If the blood sugar going down, the patient will have gluconeuropathic symptom like blurred vision, headache. A patient will go more dizziness, and if the patient has more decreased the blood sugar, he will go for deep complication of neuroglycopenic symptom like seizure. If the glucose, the hypoglycemia not treated, he will go for more deep coma. And if not treated and blood sugar reaching less than 30, he will go more the fatal complication like death because not treated hypoglycemia. So case number 6, the patient is type 1 diabetes and glargine and lispro, had frequent high fasting blood sugar. Patient has high frequent fasting blood sugar as the following. Patient measured fasting blood sugar 200, 300, 350, and one time a patient has 74 milligram per deciliter, and she had also 75 milligram, and almost all the fasting blood sugar is very high, more than 200. Her hemoglobin A1C 4.5. And before 2 weeks, when she visits the diabetic clinic, what you will do next? Increase Lantus dose or glargine dose to control fasting hyperglycemia, decrease the Lantus dose, or increase Lispro dose, or decrease the Lispro dose, or none of the above. We'll see your output, then we'll see. D, okay, C, يعني almost 50% of you chose C and D. Actually, is nobody of you chose the right answer. Okay. Also, they chose A. A is not the right answer. This is a tricky and most important statement and most practical case. Fatima Al-Khaddab and also WB, they chose the right answer, and their colleague also. The right answer is E, none of the above. Why we call this, why we not mention the right answer? Decreasing, this patient has what we call it Somogyi phenomena. Patient has high fasting blood sugar. As we know, the fasting blood sugar is related to the glargine. But before hurry to correct the glargine dose, we should mention measure the blood sugar at 3 a.m. because this is called the reactive hyperglycemia. Reactive. This is not the real hyperglycemia. This is reactive to early morning hypoglycemia called Somogyi phenomena. This patient has when they measure the blood sugar at 3 a.m. 3 a.m. the blood sugar going down than 70 milligrams. So a patient has early morning hypoglycemia. When they measure the blood sugar at 8, the blood sugar here reaching very high level, 300. So if the patient has early hypoglycemia, he will present at 8 a.m. with hyperglycemia. And also it's equal if the patient has real hyperglycemia in the same time when we measure here, the same reading, 200. So before hurry to decrease the glargine dose or increase the glargine dose, we'll measure the blood sugar at 3 a.m. or 4 a.m. 4 a.m. if the blood sugar hypoglycemia will decrease the glargine dose. If the patient has hyperglycemia more than 200, this is the real hyperglycemia, then will increase the glargine dose. So my advice to these patients presented with fasting hyperglycemia, don't be hurry to adjust the insulin. Measure the blood sugar at 3 a.m. If the blood sugar hypoglycemia less than 70, decrease the glargine dose. If the patient had hyperglycemia, increase the glargine dose. This is called Somogyi phenomenon. So I want to thank you. And if you have any question before going to the third part of the lecture, last comment. Also, another practical case I will discuss for you. This is about diabetes and very practical case. This is a 20 years old female new patient with concerned about because she had symptoms of hyperglycemia of diabetes, and she is overweight, and she is presented with hyperglycemia for the first time, and her lab shows the glucose 312 and urine analysis positive for ketones. So she is young patient, she is overweight, and the patient has very high blood sugar 300. Urine analysis is positive for ketones, and ABG arterial blood goes normal, no diabetic ketoacidosis. Her hemoglobin A1C requested because hemoglobin A1C take 2 days to appear in the system. What will initial drug therapy strategy will be? Initiate monotherapy with metformin. Initiate combination therapy with 2 non-insulin agents. C, initiate lifestyle modification. D, initiate insulin therapy plus minus oral agents. Which preferred and instruct your patient to discharge on? This is newly discovered diabetes in young patients, and a patient with presented with urine ketone positive, patient overweight, and with no diabetic ketoacidosis. What do you think? Which one you would choose for this patient if you see this patient in ER? Okay. 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 رفعت، منال، عصم، محمد، نديم. Maria also. I think we'll go through because the time. This patient is high risk patient because the type of diabetes is not clear. It needs to diagnose this patient. We should, when treating the patient, we should know the type of diabetes. This patient is 21, so this age of type 1 diabetes before 25 is counted as type 1 diabetes till proof otherwise. So this patient may be type 1. يعني 60% or 50% this patient is type 1 by her age. And also this patient is overweight. Overweight is maybe type 2. So this patient is maybe type 1, or she had feature of type 1 and type 2. This patient also, she had picture of type 1. She had urine ketones positive. For patient with ketones, patients high risk to develop diabetic ketoacidosis. So to avoid any diabetic ketoacidosis or diabetic ketosis, insulin is preferable therapy for this patient till they have improved the glycemic control. DKA is not diagnosed because the ABG is normal. So the insulin is must for this patient, plus minus oral hypoglycemic, because maybe a patient has type 2. So we should discharge the patient in insulin, either insulin alone, multiple daily injection of insulin, or insulin, basal insulin plus oral hypoglycemic. When we saw the blood glucose 300, it means the hemoglobin A1C more than 10. So the indication of insulin, as Dr. Bender mentioned before, and I mentioned also, the indication of insulin therapy if the hemoglobin A1C more than 10. And also the indication of this patient, insulin, is the patient not known type of diabetes, not yet known. So start insulin is safest method. If you discharge the patient on oral hypoglycemic or lifestyle modification, the patient will develop DKA, diabetic ketoacidosis. This is the most serious complication of diabetes. The patient may end by death. So to save your patient, start insulin, then investigate the type of diabetes, do the antibodies. If the patient blood sugar control, then easy, and the antibodies is negative, this patient easily to shift to oral hypoglycemic. And if you know the type of diabetes. So the safest method, start insulin. Starting insulin because the patient had type 1 diabetes, and also patient ketones. Ketones, it means need insulin. And also the patient also had high hemoglobin A1C more than 10. So initiate insulin therapy plus minus oral hypoglycemic. This is the type 2 diabetes. The usual history, patient presented with the usually they start to have fasting hyperglycemia, postprandial hyperglycemia, then patient because their beta cells still function, at the end they lose the after 10 years of the history of diabetes, the patient lose the function of the beta cell. At the end, the patient needs insulin therapy. So the insulin therapy should be practically considered for a patient with hemoglobin A1C more than 10. And if the patient has ketonuria, if the patient has ketones, it means the patient needs insulin. If the patient has loss of weight or catabolic state, this is the indication of insulin therapy in type 2 diabetes. And this is the recommendation. American Association of Clinical Endocrinology, if the patient has hemoglobin A1C 9 with symptom, you should start with insulin plus oral hypoglycemic agent. So insulin is must for patient with hemoglobin A1C more than 10, more than 9, and also if the patient is symptomatic. This is the hemoglobin A1C equivalent. This patient has blood sugar 372. This the patient has here 300, above 300, the hemoglobin A1C equivalent to 12. So this patient has hemoglobin A1C around, estimated hemoglobin A1C more than 10. So this patient indicates a need of insulin. This patient has what we call this one. So this patient has a type 2 diabetes, or insulin resistant sign is acanthosis nigricans. It darkest color of the skin, especially in the neck and also in the axilla. This indicates insulin resistant. It means type 2 diabetes. But patient with this may be associated with type 1 plus type 2. Type 2, this is insulin resistant, it means. But if the patient has feature of type 1 and type 2, you should start insulin, then investigate of antibodies. If the antibodies is positive, this patient needs insulin. If the patient is antibodies negative and blood sugar control, you can easily to shift the patient in oral hypoglycemic. Type 1, because feature of this lady, she had 21 age is less than 25. This is indicate type 1 feature. The patient has positive ketones, it goes with type 1, but also the patient has feature of type 2, like BMI more than 24, she has overweight, and her uncle is diabetic because family history is associated with type 2, and also she had dark discoloration in her neck. This is acanthosis nigricans, goes with type 2. So this patient has feature of type 1 and type 2. So this patient should start an insulin plus oral hypoglycemic to cover the possibility of type 1 and investigate for antibodies to exclude type 1 diabetes. So this feature of type 1, usually age less than 25 goes for type 1, more than 25 type 2. Body mass index is high for type 2, less than 24, decreased weight in type 1. Positive ketones usually in type 1, and DKA also in type 1. Family history usually most important in type 2, but few percent in type 1 diabetes. So case number 2. This years old, 59 years old patient with diagnosed type 2 diabetes 5 years ago, presented to the clinic for appointments. He had history of hypertension, dyslipidemia, both currently will control on medication. So this patient's type 2, around 6 years. Control hypertension and dyslipidemia and medication. He had maximum dose of glyclazide, MR 120 milligram per deciliter per day. He tell you he's correct about, he's concerned about the sore on his feet. So this is a sign of diabetic neuropathy. His today visit hemoglobin A1C 8.8. So the target hemoglobin A1C for a patient with 60 should less than 8. After the discussion, his opinion, you decide to start sitagliptin or empagliflozin to the regimen. Compare sitagliptin to empagliflozin, what you will expect him to experience. A, both drug cause weight neutral, more hypoglycemia in empagliflozin. Empagliflozin injectable, while sitagliptin is oral tablet. All above drugs have high risk of weight gain and hypoglycemia. Empagliflozin can cause dehydration and more blood pressure control. Which about a right statement about the empagliflozin or sitagliptin? Can I see your input? I think, mashallah, a lot of you chose the right answer. Right statement and right answer is E. Empagliflozin cause dehydration and more blood sugar control and no risk for hypoglycemia. So empagliflozin can cause dehydration and more blood sugar control. So the Januvia DDP4 inhibitor cause insulin excretion, increase insulin secretion, decrease glucagon secretion, decrease gastric emptying, and no cause for hypoglycemia. And the weight caused in sitagliptin is neutral, so it's not decreasing weight, not increasing the weight. Weight is neutral, and no risk for hypoglycemia. SGLT2 inhibitor and empagliflozin cause weight reduction, decrease the blood sugar, decrease weight, and also improve the hemoglobin A1C. And it's very important medication for those with high risk cardiovascular risk. It's counted as a first line of therapy in patient with high risk cardiovascular disease or secondary as secondary prevention, and also a primary prevention of the high risk cardiovascular patients. Case number 3, I think this is the last case I will discuss today. The patient is blood sugar, I can see. This is 6 years old male patient, came with history of frequent hypoglycemia in ER. This is a very practical case during Ramadan. He is 60 years old male patient, presented with history of frequent hypoglycemia in ER with blood sugar 30 milligrams. So a patient has severe hypoglycemia, this elderly patient. He known to have type 2 diabetes and fasting Ramadan on Dawanil. Dawanil is gilbenclamide, oral sulfonylurea. He's taking 10 milligram BOPID, and he take also metformin tablet. His investigation shows creatinine was normal creatinine, and he had hemoglobin A1C 9. So the target hemoglobin A1C for 6 years is less than 8, and he had increased weight. So what best combination cannot be discharged on this patient? We'll give him Dawanil. They look, the question look for wrong statement. Which the wrong statement? Dawanil, gilbenclamide, have tablet daily, or sitagliptin and novonorm. Novonorm is retignolides. Lantus and homolog, Lantus or Lispro. Levemir, Detemir or Lispro. Vildagliptin 50 milligram and Lantus. Which medication cannot be discharged for this high risk patient with fasting Ramadan on oral gilbenclamide or sulfonylurea and metformin? Which medication should be avoided and discharge this patient to not develop another attack of hypoglycemia? Which statement is wrong? Kamran, right. Rifat, right. Okay. Okay. MashaAllah, I think 90% of you chose the right statement. Wrong statement. Wrong statement is Dawanil half tablet PID. Who chose A? This is the right choice, and wrong statement. Discharging this high risk patient, type 1, type 2 diabetes on sulfonylurea, they have high risk to develop another attack of hypoglycemia. As we said, this type of patient, especially elderly patients, we should avoid any medication causing more hypoglycemia like sulfonylurea. Sulfonylurea is very high risk for developing hypoglycemia, especially in this elderly patient during fasting Ramadan. As I said before, they should decrease the dose before going fasting Ramadan. And if the patient developed hypoglycemia, he should admit it to the hospital for observation for 24 hours to avoid any recurrent hypoglycemia. And when you discharge this patient, you should discharge a patient on the medication not causing hypoglycemia. The medication is not causing hypoglycemia, like sitagliptin, DPP-4 inhibitor, and retignolides. Retignolides, it's counted as short-acting secretagogue. It risk low risk for hypoglycemia. Insulin is advisable for this type of patients, not control on DPP-4 inhibitor alone. and we can add to the DD4 inhibitor, and we can adjust, and the insulin is causing less hypoglycemia compared with the sulfonylurea. Levemir homolog insulin again is safest medication for this type of patients. DD4 inhibitor, vildagliptin, and also insulin is safest medication for this type of patients. I think I will stop here. I want to thank you for attending this course, Diabetes Made Easy. I want to thank Riyadh, Durrat Riyadh company for hosting and arranging this course. I want to thank you for your interaction for this interactive cases for today, and also with my colleague Dr. Bender. I want to thank you for attending this course, inshallah, hoping to see you for the next event with inshallah my colleague and other coming courses. And inshallah, we plan to do a lot of courses about diabetes and also endocrine diseases with the Durrat Riyadh. I think I want to extend thank to my colleague Dr. Bender Damanhouri for helping me for presenting this course. And if you have any question, I am ready to answer the question before we conclude. And a lot of you asking about certificate and also the hours. I think Durrat Riyadh will answer you. I am responsible for scientific material, and the other issue will the logistic with Durrat Riyadh personnel. Thank you all for your participation in this course. I want to thank you again, and inshallah hope to meet you again in coming events. وصلى الله وسلم على نبينا محمد والسلام عليكم ورحمة الله وبركاته.